is with sense of pleasure Member Health, Niti Aayog, formerly Head Department of Pediatrics, New Delhi, All India Institute of Medical Sciences. He is a very renowned, globally recognized academic and political exponent. We are lucky to have him amongst us at some stage to inaugurate the NAMSCON2020 oration presentations. I am indeed extremely grateful he spared his valuable time. He will be able to spare his valuable time sometime in between the session, in spite of his tight schedule in the vogue of COVID-19 torpedo. On behalf of NAMS and my own behalf, I gratefully accord a very warm welcome to Dr. Vinod Paul, who happens to be our star fellow. Also, since he has to go because of his commitments immediately, I thought of saving time. I would not individually be able to acknowledge and welcome the eminent participants in this event. However, I do wish to acknowledge Dr. B.M. Heve, who happens to be very senior fellow of our academy and is a very noted academician, educationist, former Vice Chancellor of Manipal Academy of Medical Sciences, a university in itself, and Dr. B.M. Heve has a special affinity for our Ayurveda and amalgamation of Ayurveda with modern medicine, with methodical research. He is a great exponent about it. And for Rajaram Oration, R.V. Rajaram Oration, he was to chair, and he is on the trying to connect. There is some problem at the moment, and Dr. O.P. Kalra is the chairperson with him. We have for Achanta Lakshmipati Oration, Dr. P.M. Tandon, a very noted neuroscientist of Padam Vibhushan and exponent of in India. He would be chairing this Lakshmipati oration with Dr. M.K. Mishra, U.K. Mishra, who happens to be was the former dean of Sanjay Gandhi Institute of Postgraduate Medical Education. Dr. P.M. Chotani oration is chaired by Dr. Sarman Singh, the director, Bhopal Institute of Medical Sciences, India, and Dr. Kameshwaran, a noted otolaryngologist of our country from Chennai, who has established the foundation of MERF. He would be the chair with him. Then Dr. V.R. Kanolkar oration is going to be chaired by Rajeshwar Dayal, Dr. Rajeshwar Dayal, an eminent pediatrician from Agra, and Dr. Digambar Behre, an eminent pulmonologist and Padam Shri Awardee from Chandigarh, PGRI Chandigarh. And we have last oration of the day, Dr. J.S. Bajaj oration, to be chaired by Dr. D.K. Taneja, a noted orthopedic surgeon from Indore, and has been president of the Asian Association of Orthopedic Surgeons, Indian Association of Orthopedic Surgeons, and many other laurels with him. Then Dr. Nija Vatla is our council member and a very enthusiastic young person from a Department of Orthopedics, All India Institute of Medical Sciences. I would like to extend warm welcome to all the chairpersons of the orations, the orators, the council members, the emeritus president, Dr. P.K. Dave, the chair finance committee, Dr. S.S. Deshmukh, the chair academic committee, Dr. P. Ramachandran, the office bearers of names, the vice president, Dr. Sanjay Vadva, the treasurer, Dr. Meera Rajani, the academic advisor, Dr. K.K. Sharma, the fellows and the members of the names joining physically or offline or online, and other participants and students from various medical and allied health sciences institutions from all over the country. I welcome them all on my own behalf and on behalf of all NAMS. I now again like to request the Honorable Chief Guest, Dr. Vinod Pal, the member of Niti Aayog, in case he could join formally and inaugurate the NAMSCON2020 oration and give his blessings and guidance to NAMS at some stage during this session of today. Dr. Deep, would you be able to connect with him? Because if yes, we would like request him to join now, or let's know in case he would be able to meet sometime later. Over to Dr. Deep Srivastava, please.
Encouraging words. Now we start with the first oration, R.V. Rajan oration. I would request Dr. K.K. Sharma, Council Member and Academic Advisor, to please introduce about the speakers of the first oration, Dr. R.V. Rajan oration. Dr. K.K. Sharma, please.
I have been
Double Vice Chancellor of Manipal University, co-chairman of the PGHS Diabetes Research Center, Chennai, and the chairman of Bharatiya Vidya Bhavan, Bangalore. He was awarded Dr. D.C. Roy Award in 1999. In 2010, he was honored with the Padma Bhushan, one of the India's important civil awards. Dr. Kalra, Dr. O.P. Kalra, an eminent nephrologist of the country and President Vice Chancellor of Pandit A.D. Sharma University of Health Sciences. He is currently holding the position of President Association of Indian Health Sciences Universities. In the past, he has held the position of Dean, Faculty of Medical Sciences, University of Delhi, and Principal of University College of Medical Sciences, University of Delhi. He has a teaching experience of over 38 years and as Professor of Medicine for more than 25 years. Thank you.
Over to Dr. Deep.
Over to Dr. Deep.
Dr. Deep, you can speak now.
Dr. Kalra, sir, I think Dr. Hegde is not connected, so you please tell about the oration and introduce Dr. Parida.
okay. Should I start, sir?
Yes, sir, please.
Okay, thank you very much. First of all, my regards to Professor Saroj Chudamani Gopal, the President NAMS, and Professor P.K. Dave, Emeritus President NAMS, and very distinguished members and participants for this 60th NAMSCON. First of all, my sincere thanks to the Honorable President and the Emeritus President for giving me this opportunity to be co-chairing this very prestigious oration along with Professor B.M. Hegde. Unfortunately, as Professor B.M. Hegde is not able to join because of certain technical problems, so I'll be introducing about the oration to begin with and subsequently about the speaker. As far as Dr. R.V. Rajan oration is concerned, this was instituted in the year 1977 in order to invite an eminent medical scientist to deliver an oration on the subject which has relevance in health-related matters and needs of the country. The brief biodata about Professor Dr. Ramakrishnan Venkat Rajam. He was born on January 9th, 1893 at Kumaralingam, Tamil Nadu. He did his MBBS from Madras University in 1918. Did his MRCP in venereology from Edinburgh 1931, and this was followed by FRCP and FRCS from Edinburgh 1953 and 59. He joined Madras Medical College as faculty in 1920 and superannuated as the principal and dean of this college. He was the first president of Indian Association of Dermatology and Venereology in 1947 and member and vice chairman of WHO Expert Committee on Venereal Diseases from 1948 to 1958. And he was also chairman of the Expert Committee on Venereal Diseases of the Indian Council of Medical Research 1948 to 1960. He was elected as Fellow of NAMS in 1961, and he was elected as 4th President of National Academy of Medical Sciences from 1971 to 72. Coming to the orator, the speaker for this prestigious oration, I am to introduce Professor Subhash Chandra Parija. Professor Parija, whom I have the privilege of knowing him since 1997, when we were together at the prestigious BP Kerala Institute of Health Sciences in Nepal, that is for the last nearly 23 years. He is currently the Vice Chancellor of Sri Balaji Vidyapeeth Pondicherry and was formerly Director at JIPMER Pondicherry. He is a Food and Agriculture Organization expert to the Government of India and is one of the very few medical microbiologists of India to be conferred BSc, which is the highest degree in research. He is the author of more than 350 research publications and 17 books, including the most popular book, Textbook of Parasitology. He developed newer and rapid diagnostic tests, including molecular tests in laboratory diagnosis of parasitic diseases, including amoebiasis, cysticercosis, hydrated disease, which are the main fields of his research. Professor Parija has 2 patents to his credit, and he has received 18 research grants from various funding agencies in India. In recognition of his immense contribution, Professor Parija has received more than 24 national and international awards, including the most prestigious Dr. B.C. Roy Award from the Medical Council of India. Professor Parija has founded the Indian Academy of Tropical Parasitology, the only professional organization of medical parasitologists, and he is currently the president of this organization. He has initiated Tropical Parasitology, a journal which focuses on the tropical diseases caused by various parasites. Professor Parija has been member of the Research Advisory Board of BP Kerala Institute of Health Sciences, Nepal, and also of various other assignments nationally and internationally. He is editor to more than 20 scientific journals and held several positions in various professional organizations. We are very lucky that today's oration, Dr. R.V. Rajam oration, is being presented by none other than Professor Subhash Chandra Parija. Over to Professor Parija, please.
Thank you very much, Professor Kalla. Am I audible?
Yes, sir, you are audible.
Yeah. Thank you, Professor Kalla. Respected Professor Saroj Churamani, President of the NAMS, Professor Dave, Professor Deep Srivastav, and chairpersons of my session today, Professor Kalla and Professor Hegde, and all distinguished personalities. At the outset, it's my immense pleasure share content. Yeah, share content.
Sharing options not coming. Sharing option.
You just come here.
You just inform them. Sharing options. Inform. Okay. First you open. Subhash, first you open the presentation, then share.
Yeah, I have opened it, but share is not opening. Hello, I cannot share it. My presentation is open, but it's not sharing. It's not sharing.
Sunny, can you help?
Sharing.
I'm trying to help out. Yes.
Here the options in the comments.
Yes. Yes. Yeah.
They are sharing.
So I can open it.
Yeah, now it is there. Now it is there.
You can see it, yeah, correct.
Okay, will operate.
No, just then I think they will operate or I can operate from here.
Now you operate.
No, it cannot be done.
I cannot from this side. Doctor, you have to speak because I have shared the file.
Okay. They have
to operate. Okay. Greetings from Shibalaji Vidyapit. At the outset, I am extremely thankful to the National Academy of Medical Science for conferring this prestigious honor to be conferred with Dr. R.V. Rajam Oration Award. Next. This I'll be presenting my talk on the role of molecular techniques and applications of detection and identification of pathogenic Entamoeba histolytica in accurate laboratory diagnosis and the prevalence of amoebiasis. I'll first take few minutes to discuss about the primary scenario of amoebiasis in India. Then I'll mention about the recent technologies being used for diagnosis of amoebiasis and to conclude my talk on the recent future advances. I dedicate my talk to my mother, for whom I am today, and I acknowledge all her pain contributions to make me what I am today. Next. When we talk of amoebiasis, when in the beginning of this last century, on the end of the last century, 20th century, we used to call amoebiasis a 10% disease. It means 10% of the world population was believed to harbor Entamoeba histolytica in the large intestine, of which 10% of the people would be suffering from the invasive disease like amoebic dysentery or amoebic liver abscess or its complications, and of which 10% of the people would have serious morbidity and mortality. But now, with these newer concepts, newer changes, now this concept of 10% amoebiasis and epidemiology has changed drastically. That's what I'm going to share today. Next. When in the beginning of the 20th century, the main diagnosis of intestinal amoebiasis was based on the morphology, either by microscopy or by culture. Subsequently, to diagnose invasive amoebiasis, serological tests came in, and it was the complement fission test was the first serological test in 1918 to be introduced for amoebiasis. Since then, a wide range of serological tests, including most recent test ELISA testing bloods, have been used for diagnosis of amoebic liver abscess by demonstrating a specific significant titer of antibodies. Next. So in our lab, we have tried and evaluated some simple tests which can be done to measure the antibodies for diagnosis of amoebic liver abscess by the test which can be done with the help of simple microscope and simple facilities in a small poor equipped laboratories like Staphylococcus aureus test or carbon immunoassays. Although these antibody-based tests, even ELISA or SAP or CIA, can detect antibodies, but the main limitation of antibody diagnostic tests is that they cannot differentiate between recent or past infections, or they cannot be of prognostic value. Hence, an effort was made next to demonstrate antigen in the diagnosis of diagnosis of amoebic liver abscess by detection of the antigens. A wide range of tests has been carried out to detect circulating amoebic antigens in the amoebic liver abscess by various assays. Traditionally, coagglutinations and carbon counter-current immunoelectrophoresis or even ELISA all have been evaluated to detect antigens in the amoebic liver abscess. The main advantage of antigen detections in the amoebic liver abscess or invasive amoebiasis is that it's of prognostic value. It means with the cure of the patients, the antigen disappears from the circulation and it gives a clue whether the patient is clinically cured or not. Next, now when we think of the development in the laboratory diagnostics, now we must understand since 19th century, which was based on the morphometric diagnosis, that is demonstration on the identification by morphology. In 20th century, more focus was on serology, by demonstration of antibodies or antigen and other things, and mostly focus on the simple cost-effective test. Now, this 21st century, this has been shifted from morphology, from serology, mostly to the non-morphometric diagnosis like molecular proteomics, and with the recent advancement of the automations, rapid imaging, artificial intelligence, and Internet of Things, there is a great change in the scenario of many diseases, infectious diseases, including the amoebiasis. Next, so in this context, when we talk of Entamoeba histolytica, it was a century-old concept that this Entamoeba histolytica, which is a unicellular pathogen parasite, was the only pathogenic species that causes the invasive amoebiasis. But as early as in 1925, it was suggested by Brunt that there are some infections caused by Entamoeba histolytica that does not cause disease. He coined the term non-pathogenic Entamoeba histolytica. Unfortunately, during that time, he didn't have technology or strategy to confirm this concept. It took around 70 years to prove that there are some strains of Entamoeba histolytica which are pathogenic and they are given a status of new species, Entamoeba dispa. They are non-pathogenic and they never cause any disease. Similarly, another look-alike amoeba was discussed, that was Entamoeba moscoski, again pathogen parasite, non-pathogenic species and never cause any disease. Next. So, this traditionally, when we diagnose by microscopy, the strapogytes and cysts are similar, even Entamoeba histolytica or Entamoeba dispa and Entamoeba moscoski. You cannot distinguish between in microscopy which is pathogenic Entamoeba histolytica or which is non-pathogenic look-alike Entamoeba dispa or Entamoeba moscoski. Next. Cysts of all these three species are similar. Hence, the main problem is the identifications. For last 33 to 4 decades, our attempt has been made to detect accurately the pathogenic Entamoeba histolytica and to differentiate from that of non-pathogenic Entamoeba histolytica. First attempt was by detection of gymnodes, but it was of academic interest. Subsequently, in the end of 20th century, one commercial available test ELISA was available to detect 170 kDL18 of Entamoeba histolytica in the stool to confirm specifically pathogenic Entamoeba histolytica and to differentiate from other look-alike Entamoeba dispa and moscoski. But of course now PCR is lot of modification of PCR. Either conventional nested PCR or real-time PCR is the most important technology, is the most accurate method that is useful to detect and identify specifically Entamoeba histolytica and differentiate from other species. Next. So in our lab, we have devised a method for a complete process of nested multiplex PCR. Traditionally, when individual PCR was used, they used to detect separately either for entamoeba histolytica or entamoeba muscoski or entamoeba dispar. Now this complete process of nested multiplex PCR, which we initiated and we evaluated as early as in 2006. In this simple process, we collect stool samples, DNA is extracted, is exposed to the first PCR, genus-specific PCR, then second PCR with species-specific multiplex, gene loading and staining, and to identify the brand which will be diagnostic of entamoeba histolytica or dispar or muscoski. This process was taken 12 hours now. With this process has been further upgraded by the newer real-time PCR, which can be done in 3 to 4 hours. Next. So by this PCR, we could find, and from others also have found, that in essence, the most of the majority of the infections is not caused by entamoeba histolytica, but first by entamoeba dispar and another look-alike amoeba, entamoeba muscoski. In our study, we found around highest 8.8% of infection by dispar and the minimum 1.7% of infection by entamoeba histolytica. Along the same line, many studies from different parts of our country and abroad also have observed that entamoeba dispar, the non-pathogenic species which does not require any amoebic treatment, is the main predominant entamoeba species that continues to infect intestine. Next. So, in the absence of this specific test, we suggest that a multiplex PCR is useful for the differential detection of entamoeba histolytica and entamoeba muscoski and entamoeba dispar in stool samples. It has got a lot of relevance. It means if the entamoeba is entamoeba histolytica, it needs specific treatment with anti-amoebic treatment. Otherwise, even if it contains entamoeba muscoski and entamoeba dispar, it means it is non-pathogenic, does not cause any disease, and does not need any specific anti-amoebic therapy, hence contributing the savings in terms of anti-amoebic therapy. Next. So the multiplex PCR, what we discuss, is a simple, cost-effective, sensitive, and enables the differential detection of histolytica, dispar, and muscoski in human stool samples. This concept now being widely used for diagnosis and specific detection of this entamoeba species in stool samples. Next, we wanted to evaluate non-stool specimens. We wanted to evaluate urine. Next, as a specimen for demonstration of the DNA in this urine. As we know, urine as a clinical specimen is a non-hazardous, is collected easily and frequently without causing an inconvenience to the patients and can be collected by non-invasive procedure. Next. This urine, next please. We demonstrated, we evaluated system PCR in which we demonstrated entamoeba histolytica DNA in urine. We demonstrated that in active cases of amoebic liver abscess, entamoeba histolytica DNA is excreted in the urine, and on treatment of the patients, the DNA disappears from the Next. Next. PCR for detection of DNA in the urine, detection of entamoeba DNA in liver abscess for the diagnosis of the liver abscess. Next. PCR for detection of DNA in the urine. The result of the present study indicates that the PCR can be used to monitor excretion of entamoeba histolytica DNA in the urine as a prognostic marker during therapy of amoebic liver abscess with specific anti-amoebic drugs. In the present study, none of the urine results were positive for either dispar or muscosi, which confirms the non-invasive nature of this species. Next. Next. The present study for the first time demonstrated that DNA in the urine can be demonstrated and the specimen can be used for diagnosis of the invasive amoebiasis. However, the advantage of urine as a specimen has many. It can be collected easily and frequently without causing an inconvenience to the patient, and this would make the urine as a specimen of choice, particularly children, elderly, and those unwilling to give the blood for investigations. Next, we made an attempt, next please, that another specimen saliva, which can be used as a specimen for detection of the DNA in the saliva. In the DNA in the saliva is a good specimen, and we established for the first time that Entamoeba histolytica DNA can be detected in the urine by PCR and can be used as a diagnostic aid to specifically diagnose Entamoeba histolytica infections. Now, with this concept that we do have pathogenic Entamoeba histolytica and we do have non-pathogenic Entamoeba dispar and Entamoeba moscoski, and we also know that non-pathogenic Entamoeba dispar or non-pathogenic Entamoeba moscosi do not need any treatment. So this type of study has been conducted in many centers in India and abroad, and they have seen and they have observed that Entamoeba dispar is one of the most predominant non-pathogenic amoeba that is present, that is harbored in the large intestine. Next. We also demonstrated for the first time Entamoeba moscoski. Entamoeba moscoski was studied for the first time in India, and the epidemiological studies and clinical diagnosis of Entamoeba histolytica associated infections, which are based on morphological examinations, are prone to error. PCR, in essence, is therefore essential to distinguish histolytica from Entamoeba dispar and moscoski, because one of the traditional methods, which depends mostly or largely on demonstration of the deposit or cyst of Entamoeba histolytica in the stool, and is used as a best for the treatment of the anti-amoeba therapy, is erroneous. Even World Health Organization has come out with guidelines that to confirm Entamoeba histolytica molecular test is one of the best tests that can be used to confirm Entamoeba histolytica, then subsequent treatment can be done. So in essence, by these observations, it makes a change in the epidemiology of the so-called Entamoeba histolytica, which was believed to present in large section of the population. Now, it is observed and it is conclusively proved that the non-pathogenic species, Entamoeba dispar and moscoski, form the major chunk of the infections. And in our study, the epidemiological studies and clinical diagnosis of histolytica. Okay, next. So, E. moscoski infection is the first published data from India, and also it has been subsequently reported from other adjoining parts of the world. Next. So, again also another recent study we found that hospital-based study to observe the pattern of histolytica, dispar and moscoski. It was carried out from 2013 and 16. We used a nested multiplex PCR and we demonstrated that Entamoeba histolytica was slightly increased when compared to previous finding where the prevalence was 1.7. But still then, with majority of other parasites were Entamoeba dispar and Entamoeba moscoski. So presence of Entamoeba dispar and Entamoeba moscoski DNA, of course, was also demonstrated in liver aspirates. Next. So the main essence of this therapy is that one has to find these amoebae, and to summarize, it is understood that molecular methods are extremely useful for accurate detection of Entamoeba species. And symptomatic patients showing Entamoeba histolytica identified appropriately only needs treatment. Those who have the Entamoeba dispar or moscosi do not need colonials having money by not starting anti-amoebic therapy. Next. So in conclusion, now, Disper and Moskowski are the only non-pathogenic amoeba. Now, recent report have come, another species, non-pathogenic species, Entamoeba bangladeshi. This has been documented in Bangladesh and some parts of adjoining area of Calcutta in India also. Whether such more and more non-pathogenic amoeba are to be discovered. Could there be more non-pathogenic amoeba yet to be discovered document? And finally, are Entamoeba disper and Entamoeba moskowski really non-pathogenic? Because recent studies have shown the presence of this Entamoeba disper and moskowski in the liver first. Means it's an invasive parasite coming to the liver. And second, in animal experiments, they have also documented some evidence of the infection. Definitely, in future, more studies with newer tools may answer some of these questions. Thank you very much. Next. I must thank my parents. Next, I thank my family, my co-student, and after all, I thank my students, my co-students, who have been a great support with whose contributions we have made a team and to study different aspects of this pathogenic and not pathogenic amoeba. Thank you. Thank you very much for your presence here.
Thank you, Professor. Thank you, Professor Parija, for excellent exposition of various molecular diagnostic tests in order to unravel the mystery of pathogenic Entamoeba histolytica. We know for the last so many years how amoebiasis or amoebic liver abscess has been really foxing the clinicians over so many years. Before the diagnostic tests, particularly the ultrasound, CT scan and MRI have been available, so many times we have been taken to surprise when we could not diagnose amoebic liver abscess during life, and then we lost the patient, and finally only on autopsy we were able to diagnose even a simple disease like amoebic liver abscess. I am sure the various molecular diagnostic tests which you have clearly defined, they will be very helpful in ultimately defining the true nature of the Entamoeba histolytica as a pathogenic and trying to differentiate it from the non-pathogenic species and help us further in actually estimating the prevalence of amoebiasis and also the invasive amoebiasis. Thank you, Professor Parija, very much. Now over to Professor Deep.
Thank you, sir. May I request Dr. Churabadi madam to honor Dr. Parija by giving certificate medal.
Thank you.
Parija,
Thank you, madam.
this is for you. We are honored. Your work is our excellence, and this will be handed over to you in the forthcoming convocation when we might be able to do it physically. In case we fail to do it physically, then it will come to you by post.
Thank you.
There is the medal, the certificate, as well as some honorarium.
Thank you.
Okay. So from NAMS side, I thank you, Dr. Vegre, Dr. Kalra, and Dr. Parija. And Dr. Churamani ma'am, shall I go to the next orations?
Please.
Okay. So, Dr. K.K. Sharma, please introduce the second oration chairpersons so that the second oration is started. I can see Dr. Ladani is there, Dr. Tandon and Dr. Mishra are also there. Dr. Sharma, please. Ravi, please unmute Dr. K.K. Sharma.
Ravi, I have unmuted you. Can you please Professor K.K. Sharma is not audible.
I have a pleasant duty to introduce the two chairpersons of Dr. Achanta Lakshmipati Oration, Dr. P.N. Tandon and Dr. U.K. Mishra. Dr. P.N. Tandon, Prakash Narayan Tandon, is an eminent neuroscientist and neurosurgeon of the country. He has been the emeritus professor in the Department of Neurosurgery, All India Institute of Medical Sciences, New Delhi. He was trained so many. He was a person who got his training as a neurosurgeon from University of London and obtained his FRCS and further obtained special training in neurosurgery at Oslo, Norway and Montreal, Canada. He has occupied many positions in Government of India and working as consultant at various locations in the country. He is a recipient of Padma Vibhushan, a very prominent civilian award from the President of India. Dr. U.K. Mishra is an eminent neurologist and has been the professor and head Department of Neurology and dean before his retirement from Sanjay Gandhi Postgraduate Institute of Medical Sciences, Raebareli, Uttar Pradesh. Still, he is continuing as a neurologist par excellence and involved in the patient care in the eastern Uttar Pradesh. Over to Dr. Srivastava.
May I request Dr. Tandon to please tell about the Achanta Pachi oration and Dr. Mishra to introduce Dr. Satyanarayan Lavani.
Dr. Churamani, it's a privilege to chair this oration. For 2 reasons. One, Achanta Lakshmipati was a unique individual whose whole family I happen to know personally. I'll say a few words about it, not take your time. And on the other side, Dr. Lahani, who represents the Cancer Institute, which was created by Dr. Usha Mitra, and I have been again privileged to be associated with it over the years, following several directors there. But just to say about Dr. Lakshmipati, he was an Andhraite, born in Andhra, but at that time Andhra was part of Madras Presidency. He graduated in medicine, specialized in ophthalmology, practiced as an ophthalmologist in 1918. When the influenza epidemic, I'm mentioning this because we are passing through another pandemic, he realized that that time the modern system of medicine could not do anything at all, either for prevention or for treatment of the patients suffering from influenza. He therefore took up Ayurveda, gave up his practice, developed Ayurveda to a very great limit because he thought that preventive measures in Ayurveda are helpful. He then ultimately ended as the president of the All India Ayurveda Mahamandal. After this, he had the good fortune of having a wife who was president of the Indian Congress Tamil Nadu at that time of the last division, and later became the health minister of the state. Their son-in-law, one of my greatest heroes as well as a friend, Dr. B. Ramamurthy, the most outstanding neurosurgeon this country has produced, and also the president of the National Academy of Medical Sciences, president of the National Board of Examination, and his wife was again a very distinguished gynecologist. They combined together, created a trust, and that trust donated funds not only for creating oration in NAMS, but also another oration which I had the privilege to give in Madras at the time of the 75th birthday of Dr. Ramamurthy. So you can imagine my association. It is through their trust that Dr. Ramamurthy, after his retirement, created the Achanta Lakshmipati Neurosurgical Center, which is still to be able to serve the poor people. I won't take too much of your time. I'll stop here. Thank you.
Okay, sir. Dr. U.K. Mishra, sir, please introduce the speaker, Dr. Satyanarayan Labani.
Thank you very much. It's my privilege to introduce Dr. Satyanarayan Labani. He is a distinguished scientist, G, and head of epidemiology, and scientist at ICMR Nipur. He is a PhD in statistics and fellow of Indian Society of Medical Statistics. His 31 years of research experience, published more than 113 papers with citation index of 1100. He's been awarded several honors: V.G. Prasad Award, Suraj Kali Jain Award, FSMS, and M.K. Sheshadri Award, to name a few. He is principal investigator of community-based projects on cervical cancer and several other community-based projects, and involved in the population-based registry, cancer registry. He's organized several workshops on biostatistics, and is the editorial member and reviewer of several scientific journals. So it's my privilege to introduce Dr. Satyanarayan Labani. And invite him to give his oration.
Thank you. Thank you, sir. May I request operators to provide the share icon so that.
Sunny, please help Dr. Labani.
Yeah, I got the icon.
Yeah,
I got the icon, sir.
Okay. It has been shared, sir. Dr. Labani, can you just make it full screen?
Yes, sir. I have made it full screen just now. I have made it.
Start, please. You can start, please, sir.
Respected eminent chairpersons and the participants, and at the outset, I am grateful to be honored for getting selected for this a prestigious award on my work on cervical cancer screening project implementations in NCR. And for this, I am grateful to the selection committee as well as the executive committee of the NAMS. With this, I begin my presentation. This is on cervical cancer screening implementation projects in Delhi NCR, understanding some clinical approaches. Out of the papers published in this, there are two projects especially. One is funded by ICMR and the other is funded by PATH organization through Melinda Bill Gates Foundation. So this is the area and where we conducted our project. This is Dadri Tehsil. So the entire Tehsil we have taken, and half of the Tehsil is used for ICMR project and the other half is used for PATH project. PATH project is an HPV screening along with PATH and VIA screening, whereas the ICMR project is via Willi screening. I don't need to explain the terminology, and a total of about 15,000 women are contacted, eligible women are contacted, and we could screen 65. An acceptable coverage of 65% has been met by opening screening centers, 30 to 42 centers, a maximum of 42 centers and maximum of 4 PHCs and 18 sub-centers, and by using 36 ANMs and 150 ASHAs in the area. So it is a covering the entire Tehsil, this project in covering about 78 villages we covered in this. So as I said, as I've been introduced also, I've been the principal investigator for both the projects. It is a rare event for biostatisticians to get an opportunity for clinical projects as principal investigator. And we have successfully completed both the projects, and in both the projects we have. So these are ICMR projects, and this is to demonstrate implementation of VIA and Willi screenings, and we got about 74 lakhs, and so we have set up staff are there, and we have both the projects together. We got 21 staff members we had, and these are the publications we got from the ICMR project. So the other is the PATH Indo-US PATH project. So that was funding of 1.14 crore, and we screened about 5,000 in this also by appointing 15 staff members. So our center is one of the 4 centers of the multicentric demonstration project by the PATH organization. The others are Nicaragua and Uganda, and one is in Hyderabad in India. And the demonstration of the feasibility of implementing cervical cancer using CARE HPV. So we published several international papers out of these, so a quick contrast between these two projects. Here we have 46 villages, here we have 36 villages, and the coverage is quite good. We got 65 here and we got 70% coverage here, and both are successful coverage with detection of women, and they are all successfully treated. This is the education material at different levels which we used in the community to the clinic also. So these were all developed under my supervision. And so if we talk about the HPV project, so this is the chart we placed in the screening clinic to collect self-sample HPV, self-sampling HPV by women herself, and they were ANMs gave them training, and after that speculum examination for pap smear testing, and HPV by ANM was also one is vaginal sample and the other is cervical sample, and pap testing and via. All the 4 screening tests were conducted. So this is the hybrid capture setting, and this is the care HPV, so which was meant for rural. And we in the screening, this is the first care HPV vaginal samples are taken. Next pap smear and then via sampling was done, and appropriate management procedures are adopted. A visual inspection of cervix with acetic acid via pap, and HPV DNA testing by 2 samples, I said, cervical and vaginal. So most of the reputed single tests often lack performance. So then performance, so far as our community project has come out to be, it is lower than the other centers that demonstrated. And now I talk of as a part of the total implementation, a co-testing as a single, as most of the single tests often reported lack. So I talk of combined studies. So in that, as a methodology, I say that, so the viral load, the company has given an RLU of more than 1 was considered as a positive for HPV, and the rest of the for the screening methods we don't need much of the explanation via positivity and others. This is the kind of analysis performed for each of them, and likelihood ratios were computed, and post-test probabilities were computed. So this is the guidelines which we adopted. So if we see the total 5,000 women, so these are the cytopositive, and the others are cytonegative. So they are also biopsied because we have 4 tests. So they according to cytopositive and cytonegative also we have got biopsies because the other tests are positive there. Similarly, HPV vaginal test here. Now, combined individually, the performances are like this. 53% is detection rate, and 40 for vaginal sampling, and PAP is 43, and VI is 21. These are the combinations. 2 tests together. So it fared better for VHPV and PAP combinations. Then I got a summary of using that. When we use VHPV alone, so the LR strength is like this, and CHPV provider sampling, clinician sampling or ANM sampling of HPV is better than though it is applicability at the field level is self-sampling, and this is for detecting SIM3 plus. So if we see the combination of VHPV and PAP and VHPV and VIA, so because of the feasible methods for our country has already started VIA screening on with a target of 100 districts. So in this direction, so I am talking about self-sampling and VIA. So how is the referral load if we use co-testing or if you use individual? So referral load is like this for the single, and missed lesions. So with the single, lot of missed lesions are missed. When we combine with other, so obviously the missing lesions get reduced, though some more referral are needed. These are the sensitivity and specificity. So, co-testing of KHPV with PAP or via cervical cancer system found to be advantageous. This is published, and via failed as a single test, but co-testing is considered to be a better role. And now, because self-sampling has got advantages, it avoids speculum examination, and with that we had a sample pre-survey. What is the opinion of women? So they felt that a good number felt that the self-sampling is acceptability, and though there are some concerns, so self-sampling by women, especially sampling without speculum, were well accepted and increases the alternative sampling and screening. Now I talk about some factors associated with the HPV in self-vaginal sampling in the detection of SIN2 and SIN3. So out of the total we have about any test positive we got 21%. So turned up for colposcopy 73%. Out of them 73% turned up for colposcopy directed biopsy. So this is the positivity rate by different by health provider. HPV sampling, self sampling 2.4, via 5.5, and PAP 2.8. So these are the age distribution for various screen positivities. Obviously, the higher is in the actual sexually active period, the high positivity are there. So these are the diagnoses, SIN1, SIN2, SIN3, that's what we observed in that, and their performance has already I have spoken. Now, in these projects, self-sampling acceptability was 93%. So it's a very high sample, so that we can rely on adopting such self-sampling approach in our field setting. This is the comparison of PAP positivity to via positivity in the detection of various lesions. Now, at two cutoff points of RLU, I calculated the performance less than 0.5 RLU and more than 1.5 RLU. This is what the company recommended, and this gives good performance also as compared to the 0.5. So for different age groups, this was computed, and the performance in the younger age group and high, as compared to middle age group, the performances were better in most in picking up. So for various factors, I did area under the curve with ROC analysis, because I have a continuous variable RLU values, not just yes or no, because we for different cutoff points we can assess to get a best cutoff point also. So it shows that for younger age group, so this is fairly good. The area under the curve is 0.8, and this is for middle age group 0.7, and above 50 it is 0.7 also. Again, now we have PAP positivity. So PAP positivity again is related with HPV, and the detection rates are good. And here PAP negativity also, either positive or negative, it is related. Whereas that is not so with the VIA. VIA is not related to HPV for the detection. Now, VIA negative. So among VIA negative, the HPV is showing maximum performance. I have also done the factor premenopausal and postmenopausal. So area under the curve is 0.83, and this is lower. the postmenopausal. So with this, the second component, one is combined screening I talked about, and here it is factors related to vaginal collected HPV is associated with the premenopausal, younger age, and PAP positive. So expected increase the population coverage due to sepsis. So there is always it has been the problem that good coverage is needed for a successful any successful screening program, and with the self-sampling we can achieve good coverage. With this, I thank you for providing this opportunity. I thank once again the NAMS for considering me eligible for my project work to be honored with this. Thank you.
Thank you, Dr. Lavani. Is Dr. Tandon and Dr. Mishra connected? Okay. Madam Churamani, please hand over the certificate and medal. Dr. Churamani, madam.
Please, are you connected?
Yes, madam, please.
Dr. Churamani, you can speak. You are on mute now.
Dr. Lavani, please.
Yes, madam. Yes, madam.
It's my honor to give you, on behalf of NAMS, delivered your oration. Wonderful work, very good work, and this is your medal and the citation, and it carries some check. This will be delivered to you in convocation of the NAMSCON, as and when it is likely to happen. Otherwise, it will be delivered to you through post.
Thank you so much, madam. I am highly honored.
Thank you, sir.
Madam, can you focus the medal? It is not seen. Lakshmi, please help. Yeah.
Is it visible?
Yes, madam. Now it is visible. Okay.
Dr. Lavani, please. Prayers to him. Thank you so much.
Thank you, ma'am.
Okay. Thanks to the chairpersons, Dr. P.N. Tandon, Dr. Mishra, and Dr. Lavani for your excellent work. Now I request again Dr. K.K. Sharma to please move to the third oration, Dr. P.N. Chutani oration, and please invite Dr. Sarman Singh and Dr. Kameshwar. Dr. Sharma, please come to the post G laptop and speaker.
Am I visible?
Yes, sir, you are.
So I have a pleasant duty to introduce the chairpersons of P.N. Chutani oration, Dr. Sarman Singh and Dr. Kameshwar. Dr. Sarman Singh, presently the director of the AIMS Bhopal. He has been earlier professor of microbiology and lab medicine in All India Institute of Medical Sciences, Delhi, where he established a molecular biology center. Dr. Singh is a recipient of various research awards from a number of agencies which are granting research projects like UPSC, DBT, ICMR, ICAR, and has got a number of academic and administrative experiences. He has published his research in a very high impact factor journals and is a voracious writer, not only written the books on microbiology, but also published papers which are highly quoted in various books and other publications in the journals. Over to Dr. Kameshwaran. Dr. Mohan Kameshwaran is an accomplished rhinolaryngologist, medical academician, and the founder of the MERF Institute of Speech and Learning and Hearing, a Chennai-based institution where advanced researches are conducted and doctors are trained on audiology and speech language pathology. Dr. Kameshwar was the first to perform the first auditory brain stem implantation surgery in South and Southeast Asia, and is the first pediatric brain stem implantation was done by him, and eminently known in his field of ENT. So thanks. Over to Dr. D.
Okay, Dr. Sarman Singh, please tell about Dr. P. N. Chutani oration, and subsequent to that, Dr. Kameshwaran, please introduce Dr. Mirza.
Thank you. Good afternoon to everybody. I hope I am audible to everybody. So first of all, I would like to thank Madam Churamani and Professor Dave, Dr. B, and other office bearers of the NAMS for giving me this opportunity to chair this session, which is very, very important. And the session really, it is a proud privilege to co-chair a session which is named after Dr. Chutani. Dr. Chutani, I have the privilege of seeing him personally because I was doing my MD from PGI Chandigarh. So I know a little more than what is in the brief about Professor Chutani. Professor Chutani was a well-known gastroenterologist born in undivided India, now in Pakistan. Most of the education he did from Lahore and other parts of the Pakistan. Then he served military in Middle East. Those days it was known as Persian Army. And then he returned back and got appointment as assistant professor in Amritsar Medical College. And then in 1966, as we all know, that PGI Chandigarh was established after AIMS New Delhi. So using the same act. And he was appointed as the first director, and he served for probably a longest duration up to 78, so almost about 12 years. And we know that PGI these days, everybody knows, and I know that Dr. Behra is also here, so from PGI, and we all, those who are from PGI, we always feel proud in saying that we are from PGI Chandigarh. The construction of the PGI, the various blocks, they really have the imprints of Professor Chutani, and he is highly respected in PGI Chandigarh. PGI Chandigarh, I am also told that made a documentary on him. So definitely this is great honor and for everybody. Dr. Chutani was not only gastroenterologist and able administrator, but also he was very well known for various other extracurricular activities, and some of his styles and clean shaved head and this kind of, some of his personality was totally different. He was also honored by President of India in 1978 with the 72 with the Padam Bhushan, and in his name NAMS decorated this oration in his name in 1999. So I am really highly privileged and honored that I am co-chairing a session which is named after him, and I thank you very much, all the NAMS office bearers, to giving me this opportunity to introduce Professor Chutani. So over to you.
Dr. Kameshwaran, please invite Dr. Mirza and introduce as well.
Secretary, thank you for this opportunity and this honor. It's co-chairing this very prestigious oration. In choosing Dr. B.R. Vedya, who is a professor in the Department of Microbiology at the All India Institute of Medical Sciences, Delhi, I think the National Academy has honored one of the very preeminent clinical microbiologists of this country, with more than 25 years standing. He has done seminal research and contributed in the areas of cryptosporidial diarrheal disease, molecular epidemiology of pneumocystis pneumonia, and tropical parasitic diseases of public health importance in India. Dr. Mindra is well known for his interdisciplinary research in identifying transmission and prevention of coccidia diarrheal growth, diarrheal agents with special reference to Cryptosporidium species. His study has also revealed some novel subtypes of the Cryptosporidium species. In the last 2 decades, he has played a key role in research also related to human pneumocystiosis and is a leader in this field. He was awarded the AIMS Excellence Award in the year 2013 for his contribution towards pneumocystis pneumonia research. He holds an MD degree in medical biology and is a fellow of the Academy of Medical Sciences, Indian Academy of Tropical Parasitology, and Indian Society for Malaria and Other Communicable Diseases. I am very sure if had Dr. Chudani been alive today, he would have met with his approbation and approval. Thank you very much. Now, can we request Dr. Mindra to please share and start his oration?
Sunny, please, Dr. Mindra.
Dr. Mindra, you are unmuted and you have the presenter rights. Please start.
So very good afternoon to everyone. And before I begin my distinct, respected President, National Academy of Medical Sciences, Professor Suraj Gopal, esteemed past presidents of the Academy, the chairperson of the session, Dr. Sarman Singh, Director James Gopal, and Dr. Mohan Kameshwaram, and distinguished fellows, guests, colleagues, and friends. I consider this as a great honor that I have been chosen to the prestigious Oration of the Academy for the year 2019 and 20, and I thank the Academy for the same. I accept it with all humility and gratitude, and this honor will inspire me for further academic endeavor. However, I do not know if I can match the galaxy of eminent past awardees of Dr. P. N. Chudani Oration. I would like to talk on specifically to what Cryptosporidium is and what we have done and what are the various public issues that have been concerned and that will concern the country. Before I go to the topic, I would like to give my gratitude to the eminent leader, Dr. P. N. Chudani, who was an excellent student, he was a great clinician, a great researcher, and a soldier, an entrepreneur, and a great leader. And when I read his biography, I was really thrilled with how beautifully he has managed his life during his medical career. Talking about a diarrheal illness, and no, it could have a disruptive physiology, it can have an exaggerated physiology, it can have a reversal physiology, or it can have reversible nature. But what diarrheal illness has given us to us is the legacy of cholera that has given a translational research for basic science which has been brought to the bedside. And probably that is what is the centerpiece of global effort of oral rehydration therapy. And based on this, we talk about parasitic diarrhea. There are one which is giardiasis, and then other few dysentery, and this particular organism is slightly parasites which has a high gene flow and a specialized parasites which makes low gene. And these two characteristics subsequently takes them to the niche diversification, that what particular tissue needs to be good for them to survive and so on and so forth. And then they have a resource partitioning, and that resource partitioning basically tells the severity of a particular pathogen or particular disease. Now, it's an organism which belongs to the same organism when we call it as a scientific term as a complexa, and this organism has more or less many things common, similar to the plasmodium in the sense the cycles is more or less the same, but what happens is it only goes to the gut and infers the god cell, and it has both haploid stage and diploid stage, by which it has got an asexual cycle and sexual life cycle. Now, if you look to the timeline, what has happened is it was known in 1907 by Edmund Kieser, who described in basically the gastric mucosa of the mice as well as in the intestinal mucosa after 5 years. But it did not rise to the limelight for the fact that it was mainly seen in the ruminants as well as in the birds and other places. Only when it was only in 1971 it was found as the neonatal area, which has caused loss. And subsequently, the publication of 1971 made that it is thus produces a national disease. And in 1976, there were two concomitant papers saying that this infection can be seen in two individuals. One was an immunocompetent individual and one is an immunocompromised individual. So that clearly depicts that it can happen in both immunosuppressed as well as immunocompetent. Now, what this particular organism is an improving and intractable organism, and it has a very minimalistic metabolism. They could be morphologically and developmentally quite similar. They have the endogenous life cycle, and the beauty of this particular pathogen is it is intracellular but extracytoplasmic. Which means that it doesn't go to the cytoplasm of the host, so the invasive nature doesn't exist. In addition to that, it doesn't have any kind of mitochondria so that we can have mitochondrial genes, but rather it has contingency genes which is called telomeric genes, and these genes becomes his antigenic properties to create the disease and to show that it is host specific and the site specific. In addition to that, it doesn't have any surface antigens like any other parasites. So it has the variant surface antigens like we see in malaria, we see in giardia, which makes different antigen variation and mixed things has not been seen. So it basically have certain other characteristics that I will come to. And this on karyotypic analysis of this pathogen, the chromosome 6 has been fully sequenced, and that has provided markers that essentially has given that what kind of epidemiology or what kind of diagnostic methods can be developed. Besides, the genome sequence has been done. Now, into the biology, it has a round of asexual schizogony by which it produces hydrozoites, and in the second phase of the schizogony, this makes the microgamete and the asexual cycle starts, and then the can have two paradigm. One is the thick world is stage, whereas the thin world is basically causing autoinfection. So it can have autoinfective cycle as well as it can have a exogenous cycle. Now, the virulence factor, that is said that it doesn't have any antigen, but most of the enzymes which is playing within the host as well as within the parasites makes the whole milieu to come out, and it doesn't have any kind of any variations or surface antigens. So what happens is it remains intercellular and extracytoplasmic, and that produces the disease. And this attachment of cell damage which is caused by this pathogen is very specific, that it usually prefers to have a 37 degree and a pH of 7.4 to 7.6. And if you look at this particular video, it is the distal ileum where the infections is most commonly seen, and probably that is the reason that it causes diarrhea around that place. Now subsequently, a lot of studies were carried out from 1976 onwards in different hosts, and it has got a high and produces various kind of species. And this is what gives you confirmations of the various species which has been seen, and that made little bit of epidemiology on that whether the disease is a zoonosis or an opportunist or anything else. And when subsequently the transmission dynamics was studied, it was subsequently found that the obscurity came to a growing awareness, and we could know the unravel the pathogen, and subsequently the events could be studied further. Now, the two scenario, we know that it's a fascinating but shared world of microbes, and after the AIDS epidemic, the diseases have been broadly divided into pre-AIDS pathogens and a post-AIDS pathogens, or a characteristics are a post-AIDS. So before pre-AIDS, it was mainly a neonatal disease of calves, but post-AIDS area, it was seen in HIV patients in a permanent way, but subsequently the childhood diarrhea was become another issue which concerned the public health. And if you look into the global epidemiology, the pooled cryptosporidium incidence prevalence is showing around 76 to 7.6%, whereas if you look into the developed countries and developing countries, in both immunocompromised and immunocompetent individuals, there are slight variations. Now, when we look back in 1983 and 84, when the AIDS epidemic just started, when there are some studies was conducted, it was found that in 1983 to 84, it was the age group below 5 years were considered to be the major group of children who are suffering from this. And subsequent studies, again in 1998 to 2004, 2009, showed that below 5 years children are infected with cryptosporidium. Now, subsequently, a paper came in 2018 that gives the data after the publications of If and Board is published in Nature, that after the rotavirus diarrhea, the cryptosporidium became the second pathogen which caused a lot of childhood mortality. And this brought the attention that besides HIV, it is also associated with childhood diarrhea. Now, how does the parasite get a test of the parasite gets a test of the system within the intestinal system? So, as I said, it is intracellular or extracytoplasmic. It doesn't invade. However, it produces certain prostaglandin E2 and 5-HT, and it can happen apoptotic cell death. And that produces, because of it is intracellular extracytoplasmic, it only produces changes in the crypt or in villus. Villus and crypt in both small intestine, and only crypt in the large intestine. And that leads to absorptions and cell damage. So it had got a minimalistic metabolism, mostly anaerobic metabolism, and then subsequently it can also evade the immune evasion by the process which is slightly different than any other parasites. How does it evade is, it goes through a process of microRNA mechanism with the help of TLR4 and NF-kappa beta modulations. The miRNA, which is a non-coding RNA, which can produce certain, it can regulate the excretion of both the host as well as parasite miRNA, and there is a balance and counterbalance between these that makes whether the parasite can really cause the disease or the host can really evade the disease. Now, when we studied the various reports which is available, and specifically we looked into the Asian countries, and what I found that West Asia and East Asia provided the major contribution in publications compared to the South Asia, and which we were a part of it. Then when we looked into our Indian scenario, the first publications came from CMC Bathan group, where they showed that it is positive both in the symptomatic children and asymptomatic children, giving the importance that both the disease is there in community as well as it can be manifested. And when we looked into the publications over a period of since the first publication, that we found that there were 64 publications were there, but if you look into the PubMed 140, but the 60 were the core which gives the various aspects of this. And when we looked into again the segregations from the different parts, we found the north and south are more or less equally competitive. to produce a similar amount of publications children cases and then when the children and HIV patients categorized in the various study, what we found that the children out of 9,159, 565 positive, so we can add into this, and similarly the adults with HIV were the major groups where the positivity was more. And this is what the percentage we found for publications when we extracted the information. Look, what we want to study is that we want to detect molecular methods, then we want to study the genotypes to make the host parasite coagulation, and we wanted to see the population structure which talks about the specific polymorphism, and then there is another dimension to it in the subtypes which produces the disease risk. And we took 300 clinically operant healthy like immunocompetent individuals, 300 immunocompromised, and 200 healthy population. So what we found in the immunocompetent, it was the celiac and tropical sprue were the major group whereas in the immunocompetent adults. But when we looked into the children, it was the celiac disease and giardiasis was the commonest compared to the other diarrheal diseases. And when we took the immunocompromised, it was HIV, the number, and then the transfusion recipient was suffering from ptosporidiasis. So in that scenario, we took this group of patients. So children, it was HIV number 1, and in case of man, then malignant disorders, and in immunocompromised, no. So we took 3 consecutive stool samples as it has been recommended by WHO, and we did staining techniques as well as the molecular techniques. So I will go to what exactly we did. So we did the cryptosporidium study in the 300 patients. So we got in immunocompetent, we got only 18. In immunocompromised, we got 64. So it comes to around 82. And then we also did the molecular detections by PCR assay. We used 18 as ribosomal RNA gene, and then it gave out 435 base pairs, and that gave additional few positivity. So then after we got both positive from the molecular techniques as well as in the conventional techniques, we wanted to look for multi-locus genotyping instead of single locus genotyping, and these are the various genes we used, like single subunit ribosomal RNA, TRAC1, and other genes. And we did the different PCR techniques, and we looked for different PCR products in the different genes, and then we do the restriction fragment length polymorphism, and we found, like if you see here, that we can have CPAR1 multi-genotypes, and in some time we found CPAR1 vowel genotypes, and we found the other species, that is the cryptosporidium hominis. Similarly, with the other genes, we also look for restriction fragment RFLV, and then we found certain various other kind of genotypes. So we did all these 4 genes and subjected to restriction fragment length polymorphism, and what we got is, we got C hominis in maximum in 54 cases and CPAR1 in 23 cases, and the monkey and bovine in 14 and 9 respectively out of the 8 we studied. So what we found that we are not a biased kind of pathogens, but we had the various different species into this. Now, when we looked into this sensitivity of this multi-locus genotyping, we found single strong unit ribosomal RNA was much better, and it has been reported internationally as well as the GP65 gene. For whether the species were fitting into hominis or into bovies or into other genotypes, so we did sequence with the known gene bank data, and then we basically designated all our isolates. So this is what is the scenario. And when we compared a few of the study which was made from the Vellore as well as the study from UK, we found that we are having a similar kind of sensitivity when we do the genotyping. So we basically thought that it is working nicely, and whatever we are doing is validated technically. And we got also the mixed genotypes as I mentioned. Now under the mixed genotype, the earlier study was done at Gallo, and our study was published somewhere in 2007 in Indian Journal of Medical Research, and we found the mixed infections, and that mixed infections is probably due to certain recombinations which is acting in the environment. Consequently, we looked for the population genetic structure, and then we wanted to know the allelic profile of this pathogen and to go for the sequence type, and for that reason we did a multi-locus sequence typing. The initial one was multi-locus genotyping. Here we are looking for the sequence typing, and as per the chromosome 6 of Cryptosporidium, we took 5 different genes and then subjected studied the multi-locus sequence typing, and these are the various genes. So we did a similar kind of PCR assay. I'm not going to in detail of this. So our detections was done, and all our samples were amplified using the polymerase chain reactions. And then there's a few of them. This is a representative data to say that whether you have any kind of substitutions or deletions at any particular place. So MLST analysis were earlier studied from National Institute of Central and Antibiotic Diseases. What we found that epidemiologically, whether it is in the east or in the north, the things are looking more or less similar. However, in such particular genotype, we found there are similar subtypes for different entities like this. So this is how the mention is a slightly unique feature of the particular pathogen, and this happens due to adaptive progression of. Am I audible? So there is some.
Sir, you are audible. Please continue.
Okay, sir. So this is another pathogen which basically deals with the disease risk, and these subtypes is basically due to adaptive improgressions, which can be anthropogenic subtypes or zoonotic subtypes. So in the anthropogenic, it's an admixture of populations from the within the population of C. hominis, whereas zoonotic subtypes is because of the isolation, the distance, some kind of recombinations do occur, and the subtypes which are commonly affected by this pathogen. What happens when we know that when there is a population clonal conmity, and clonal mixes coming from one origin and conmity can happen. So C. forming a little notorious to give conmity, whereas C. hominis is more clonal and rather less converted. So what we did is we wait for this CPGP 4015, which is also known as CPGP 65 genes, which is considered to be the best polymorphic marker. So we look for it and we look the products, and then subsequently whatever the product came, we sequence, and then we got different kind of subtypes. Now here if you see that if you have hominis, it is written at 1A, and if you write C. parvum, it is written at 2A. So this basically the idea is it is made in a certain manner. There is an algorithm which has been developed globally, and based on this algorithm we follow it based on the trinucleotide repeat reason, and based on that we do classify. So based on this we got so many C. hominis and C. parvum as well. Analysis, and we found most of the first C. hominis except for most of the parvum. This study, one studied in Delhi, the other one was in Delaware in 2010 by Dr. Govindil Khan and Azampur Group, and in the Vellore in 2006. So we found the distributions of this subtypes, and it has been a different percentage. In Delhi we found one particular subtype which was not located in Vellore studies, so that probably we thought this particular subtype is prevalent in Delhi. And these are the various common subtypes, and the subtypes are further taken into different kind of connotations, and this connotation makes you that it has got any relevance. Now why we do this subtyping? What is the need of this? If you look at study in 2019 from Swansea in the United Kingdom, we showed about the subtypes has got the relationship with the various outbreaks. And if you look into this graph, you see the different subtypes of recreational water communications, whether drinking water, there is anthropogenic person to person and certain others. And if you look into the second graph, you will see that there is a variation in the number in different outbreaks. So most of these cryptosporidium causes waterborne outbreak, causes foodborne outbreaks, causes other recreational water outbreaks. So we have not studied in India, studied in US and UK, giving a clear segregation that which particular subtype has what kind of disease risk as well as an outbreak. So now, translating to our study into clinical studies, what I found that we cannot really make that what is the amount of parasites which is going to make a dent in the severity of the disease or in the mildness of the disease. But there are few studies which are shown in the experimental model that the correlation of tissue, suppose if it is a plus 1 to 10 per villus or trapped in the small intestine, it gives a moderate colonization and the disease can be less severe. But if it is more than 25 to 30 per villus or trapped in small intestine or only in crypt, of the disease accordingly, besides the other multifactorial factors like the host immune system and so on and so forth. Now the inoculum is not clearly known, but it has been shown that if it is 10 to the power 6 to 10 to the power 7, the chronic diarrhea will remain for quite long time and it can have an extraintestinal relationship with like certain hepatobiliary disorder. So it was published in 1994 in Infection Immunity, and it's a seminal publication to say that what kind of clinical manifestation can be seen depending on the colonization and the inoculum. So it can happen in the immunocompetent children, and it can also happen in the colon, and if the colonic cryptosporidiasis is quite a devastating clinical manifestations. Now, if you look into the immunosuppressions association with cryptosporidiasis, it is not immunosuppressions can really cause this. That is the only that it's close to the forefront by causing the disease, and when the CD4 count is usually 50 and was shown in 1992 as well as in 2001. And cryptosporidium diarrhea, it could be asymptomatic, it's 24%. It can have a transient infection in 29%, chronic diarrhea 60%, and familial infection in 8%. So many of the population is found within transient and chronic diarrhea. So and recently a publication in the plus neglected tropical diseases has shown, in fact requested that cryptosporidiasis should be designated as a tropical disease. So our country and Anita, both hospitalizations. So these are the various publications I have just compiled to know that what kind of HIV infected individuals since 1995 to 2002 as well as from 2003 to onwards. Now the second issue with the clinical cryptosporidiasis is basically the malnutrition and malabsorption. So it takes a massive toll on the infants and toddler, and it is not seen in older children. So probably some kind of idea of natural immunity in older children has been documented, and probably that might look and the malnutrition cryptosporidiasis has been shown by many as a synergistic relationship or a vicious cycle, in the sense malnutrition can predispose cryptosporidiasis or cryptosporidiasis can lead to malnutrition. However, we are not sure about those kind of equations and relationships, so it needs to be further studied. And we studied in 2008 a paper of the digestion disease science. We showed that cryptosporidium around 21% was positive in children with in adults and children around malabsorption syndrome, and it has been highly quoted in both in the country as well as outside to say that cryptosporidiasis can cause malabsorption. And we also look for compiled most of the study which is related to children, and Dr. Marthan's study has been well quoted in the sense it of the children, children should also be screened. Now we also look for clinical sporidiasis in flowers. There are only 3 or 4 studies. So this is coming one from Bangalore and one from Chandigarh and from our study. And we found that different percentage of transplantation is based cannot be generalized, but we know that it is present. So all transplantation should be screened, whether it is during the graft or post-graft situations or after starting the chemotherapeutic agents, so that we can see that what exactly is the incidence of cryptosporidiosis in this group of patients. Now, though it has not been reported in humans, but neonatal cryptosporidium diarrhea in cats has shown that a concomitant rotavirus and coronavirus infection has been seen along with the cryptosporidiosis. Now, when we are talking about coronavirus 19, I think it gives us an impetus that we should look whether rotavirus and coronavirus has any synergistic or any kind of summative role in causing the infections. Now, regarding treatment, the progress in treatment development has been very, very poor because of this cryptosporidium being very cryptic and valuing the metabolism very less, having very salvage pathways being used. So we do not have a clear-cut mechanism to develop a drug. So we do not have a clear antibiotic. No prebiotics has been properly given, though there are a few studies. No prebiotics as well as no symbiotics. So these are the areas needs to be opened, and subsequently with the novel rise of recent CRISPR-Cas19 and the certain genetic modifications, probably this is the area needs to be seen to take care of the untold miseries of the children. However, methaxygenamide is an FDA-approved cryptosporidiosis that also has shown a very good results in a healthy host, but not effective in AIDS patient. So it doesn't help the immunocompromised individuals. So I believe this is one area which needs to be studied in this particular pathogen. So what are the yearning gaps? The yearning gaps, what we have seen in this particular pathogen is the parasite and host immune system has not been well-made, so we do not know which particular host mechanism or parasitic mechanism can be exploited to use for any kind of vaccines or drugs or so on. So, in addition to that, the genetic tropism, whether it is an HLA linkage or any kind of other immunological background, has not been studied throughout the world. And this work needs to be studied, and I think probably that's the area we need to go about. And the public water supply outbreak, private water supply, swimming pools has not been studied in the country, and so we should be officially allowed to study without making any negative impact on that, so that we know how much is under research or how much is under reported and whether this particular pathogen is causing or not. As most of the research funding is more focused on intervention than basic research, I feel the untold sufferings of infants, children and parents should be considered from the humanitarian ground, and the loss of livestock which is happening in the parks and other things should be looked from the economic considerations. And finally, with this, I wish to acknowledge and thank you the help, the support, thank the help and support received from various government funding agencies, specifically from ICMR and CSIR, and I thank my directors and dean of Indian Institute of Medical Sciences New Delhi for carrying out most of my studies, and I thank all my colleagues who collaborated, and my students who really did the venture. Thank you very much.
Over to Dr. Sarwan Singh and Dr. Kameshwaran, please.
Thank you very much, Professor Mirza. It was beautiful and very detailed exposition of very detailed work on your part. And on behalf of the Academy, I would like to place on record our sincere appreciation for your oration. Thank you very much.
Thank you, sir.
Dr. Sarwan Singh, sir.
Thank you, everybody. And I think we know each other, Dr. Mirza and I have worked together, so we have long association. And I know that he is a wonderful parasitologist, working very contributing significantly. And I congratulate Dr. Mirza, and I thank the NAMS. Thank you very much. And I close the session with that. Over to Madam.
Yeah, Dr. Chudamani, Madam.
Thank you. It gives me great pleasure in awarding this medal and citation and a check to Dr.
Mirza.
Dr. Mirza. Dr. Mirza has done a wonderful work on this great parasite. I'm sure his work would initiate good recovery, some health initiative, some treatment initiatives will come out of, as he has indicated. Thank you so much, Dr. Midha.
Thank you, ma'am. Thank you very much. Namaskar, ma'am.
On virtual right now and actual later on.
Thank you.
Okay. Thank you, madam. Thanks to Dr. Sarman Singh and Dr. Kameshwaran and also Dr. Mehta for his excellent work. Now we move to next oration, Dr. V.R. Khanolkar oration. Dr. K.K. Sharma, please introduce the speakers and chairpersons.
Thanks, Dr. Swasan.
Yeah.
So, I am pleased to introduce the two chairpersons of Dr. V.R. Khanolkar oration. Dr. Rajeshwar Dyal. Professor Rajeshwar Dyal presently is the professor and head Department of Pediatrics, SNL College, Agra. He is a pediatrician par excellence and specialized especially in the tuberculosis in children. He has received for his researches and service to the society Dr. B.C. Roy National Award in 2016. He has been Vice President of Indian Academy of Pediatrics. He has been Chairperson of Scientific Advisory Group on Tuberculosis of International Pediatric Association. He has been Chairperson of the Task Force on TB of Asia Pacific Pediatric Association. And he has published a large number of scientific papers which are quoted in the books of pediatrics and in the researches of like-minded researches and thesis work in the country. The other person chairing the session is Dr. Digambar Behra. He is an eminent respiratory disease and pulmonary medicine specialist of the country. Till recently, he has been the professor and head of the Department of Pulmonary Medicine in Postgraduate Institute of Medical Education Research, Chandigarh. He has done a lot of work, especially in the respiratory diseases and pulmonary medicine, which has been recognized internationally as evidenced by a number of publications which have been quoted in the books and researches in the same area. He has received Padma Shri Award by the Government of India and decorated by the President of India for the same purpose. Till recently, he is also advisor to newly created aims in the country. So both the Rajeshwar Dyal and Digambar Behra are very prominent scientists, and we are lucky to have them as chairpersons of this session. Thank you. Over to Dr. B.
Okay, Dr. Rajeshwar Dyal, good evening. Please tell about the oration, Dr. V.R. Khanolkar oration, and then Dr. Behra about the speaker.
Good evening. Am I audible?
Yes, sir.
Am I audible, sir? Yes?
Yes, you are, sir.
Thank you. It is indeed a privilege to join the galaxy of scientists speaking in NAMSCON today, especially Dr. Deshmukh, Dr. P. Tandon, Dr. Dave, Dr. Digambar Behra, Dr. Kameshwaran, etc. I'm most grateful to Professor Saroj Chudamani Gopal for inviting me to be here today. About the oration, Dr. V.R. Khanolkar was born on April 13, 1895. He studied medicine in the University of London and obtained his MD in pathology in 1923. He joined as Professor of Pathology in Raj Medical College and St. G.S. Medical Colleges, Mumbai. He was also closely associated with the Tata Memorial Hospital, Mumbai, and served as the Director of Laboratories and Research. The Government of India appointed him as the National Research Professor of Medicine, an assignment that he held with distinction for 10 years. He was Vice Chancellor of Bombay University from 1960 to 63. His major contributions to the epidemiology, pathogenesis, and pathology of cancer received national and international recognition.
Smoking and Chewing of Tobacco in Relation to Cancer of the Upper Alimentary Tract, published in the British Medical Journal in 1955, remains one of the most cited papers. He was professor of the International Cancer Research. He was the president of the International Cancer Research Commission from 1950 to 54. He was also the president of the International Union Against Cancer. His major interests include leprosy as well. He was the founder president of the Indian Association of Pathologists and Microbiologists. His publications include 3 books on cancer, on leprosy, and more than 100 scientific research papers. The President of India honored him with the award of Padma Bhushan in 1955 for his distinguished service to humanity. Dr. Khanolkar passed away in October 29, 1978. On a personal note, because my area of interest is leprosy, I happened to read one of his papers published over half a century ago. And I must say, at that time with the resources available, it was a brilliant piece of work. Dr. Khanolkar Oration was established in the year 1987 by the National Academy of Medical Sciences. To rate the outstanding contributions of Dr. Khanolkar, the first president of the Academy. Now over to Dr. Bora for introduction of the speaker, please.
Thank you, Professor Dayal. Respected Professor Chudamani, Professor Dave, Dr. Srivastava, and good evening to everybody. It is my privilege to introduce Dr. Shyam Singh Chauhan, who was professor and former head of the Department of Biochemistry at the All India Institute of Medical Sciences, New Delhi. He did his Master in Sciences in Biochemistry from the Kurukshetra University and a PhD in Medical Biochemistry from the Delhi University. Subsequently, he did his postdoctoral training from the University of Pennsylvania School of Medicine, Philadelphia, USA, and the National Cancer Institute, NIH, Bethesda, USA. He joined the All India Institute of Medical Sciences, New Delhi, as an assistant professor in biochemistry in the year 1992 and promoted to the post of professor in the year 2005, and he served as the head of the department for a period of 2 years. He has been awarded and honored with a number of awards that includes few of them are the Ames Excellence Research Award in the year 2018, Fellow of the National Academy of Sciences, and then he is also a FMS and National Academy of Sciences, and he is a life member of the many professional bodies. He is a member of editorial board, research, the reports in the biochemistry, Indian Journal of Clinical Biochemistry. He had more than 100 original research papers in indexed and peer-reviewed journals, and he had been an invited reviewer and had many chapters in many books. So now, may I invite Professor Chauhan to deliver his talk. Professor Chauhan, please.
Professor Chauhan, you are unmuted. Please begin.
Okay. Can the share button be share screen button be activated?
Yes, sir. It has been activated. You can share now.
Okay. At the very outset, I would like to thank National Academy of Medical Sciences and member of the jury for considering me worthy of this award, this prestigious award. I'm going to speak on systemic vaccines and their prognostic and therapeutic relevance today. And what we have done, I'll very briefly share with you. In these slides today, hello?
Yes, sir. You are the presenter. You can move the slides.
Okay. Okay. Thank you very much. Leukemia, as you all know, is a malignant progressive disease in which the bone marrow and other blood-forming organs produce increased number of immature abnormal leukocytes. They suppress the production of normal blood cells, leading to anemia and other symptoms. Annual world incidence, age-to-life incidence is 4.7 per 100,000, and death rate is about 3.7 per 100,000. These are some of the common symptoms of leukemia, and I'm not going to spend a lot of time on this. It includes weight loss, fever, frequent infection, so on and so forth. And as you can see here, these blood cells are of two types, lymphoid origin or myeloid origin, and the leukemia, based on these, the leukemia can be of lymphoid origin or myeloid origin. And my lab has been working on the leukemia of myeloid origin, which can be acute as well as chronic, depending upon the onset and duration. And another thing that I would like to introduce before I come to the main talk is 16 cathepsins, on which my laboratory has been working for the last 20 years. Cathepsins is a Greek word which means to digest, and the digesting organ in the cell is a lysosome. So essentially these are lysosomal proteases which are supposed to be present only in the lysosomes. Now they have been divided into different types based on the amino acid which is present at the active site, and I'm going to talk about 16 cathepsins. So there are about 11 cysteine cathepsins. All of them contain a cysteine histidine ion pair in the active site, which is essential. They are involved in a number of essential cellular functions such as protein turnover and degradation, antigen processing, hormone activation, lysosomal death pathway, and so on and so forth. This list is by no means complete. Now, cathepsin, both cathepsin B and L are cysteine cathepsins on which my laboratory has been working. Cathepsin L is an endopeptidase, and cathepsin B can act both as endo and ectopeptidase. Now, they are supposed to be staying in the lysosomes, but if they are released from the lysosome, then they are sequestered by the endogenous inhibitor, which are known as cystatins. And if they are not sequestered by this inhibitor, it can cause cell death. So that is a mechanism, protective mechanism, secondary protective mechanism. Now, long time back in 1991, we demonstrated that these proteases are overexpressed in a number of human malignancies, and these are different cancers in which it is overexpressed. Now, not only it is overexpressed, but although it should be staying in lysosomes, but majority of cathepsin L synthesized by malignant cells is secreted into the extracellular matrix into the extracellular medium, as has been shown here. About 80% of the total secreted protein by malignantly transformed cells is cathepsin L, as opposed to what is present in the cells. So if this secretion is blocked, then it abrogates the tumorigenicity, it abrogates the invasivity as well as the metastatic ability of the tumor cells. These experiments have been done in nude mice, and I'm not going to spend a lot of time on that. Also, we found and characterized the gene promoter, and we identified multiple mRNAs. There are 5 mRNAs which are transcribed from 2 different promoters from this gene. The gene for cathepsin N is located on chromosome 9q2122. Now, this is the basis why we started working on cathepsin L, expression of cathepsin L in leukemia, because as you all know, CML or chronic myeloid leukemia is characterized by reciprocal translocation of chromosome 9 and chromosome 22, and this translocation on chromosome 9 is very close to the locus which is where cathepsin L gene is present. So, by this, we wanted to ask two very simple questions, and that is, does this chromosomal translocation has any effect on cathepsin L expression in leukemia? Also, can alteration in the expression of this protease have any prognostic, diagnostic, or therapeutic significance in CML? To address this question, we did a very simple and straightforward experiment. After ethical clearance from the Institutional Ethical Committee, we recruited 47 CML patients, 30 patients with systemic infection, and 50 healthy volunteers, and we isolated peripheral blood mononuclear cells by picoid density gradient, and then we performed real-time PCR, cathepsin L assay, Western blotting, and then isolated DNA subjected to epigenetic changes in the promoter region. And these are the patient characteristics. I want to draw your attention to the fact that leukocyte counts is very high in CML patients as compared to the normal healthy volunteers, but in systemic infection patients it was higher than this, but lower than the CML. Out of these 47 patients that were recruited, 38 were in the chronic phase and 9 were in accelerated phase or blast crisis. Now, when we estimated the cathepsin L activity, there was a significant and robust increase in expression of cathepsin L in chronic phase, but surprisingly, the expression in accelerated phase or blast crisis was comparable to the patient controls or normal healthy individuals. This is a cell line which is derived from the blast crisis patient K562, and here the expression was comparable to the accelerated phase or blast crisis. Also, these findings were corroborated by the increase in mRNA levels and protein levels, as you can see here in CML-CP. The 3 bands cathepsin L synthesized as a pre-proenzyme 43 kilodalton, which is processed into enzymatically active 26 kilodalton form, and you can see expression of all these 3 forms was higher in chronic phase as compared to the patient controls. So, there was increase in cathepsin L activity and mRNA levels, protein levels, but there was a decrease in the endogenous inhibitor, which is cystatin C. And we found an inverse correlation between enzymatic activity and cystatin C in all these patients. So what we found so far is that, that in accelerated phase or blast crisis, the expression of this protease was low, and as we all know, the disease progresses from chronic phase to accelerated phase and blast crisis, and prognosis is poorest in case of blast crisis, followed by accelerated phase, and then it is really good in chronic phase. So when the expression of this protease is high, then the prognosis is better. When it is low, the prognosis is poor. We also found BCR-ABL is the signature protein which is expressed, which is found in CML, and if you express this protein, it gives the phenotype of CML to normal cells. What we found is that there was a direct correlation, direct and very strong correlation between BCR-ABL mRNA and VEGF mRNA, and BCR-ABL as well as cathepsin L mRNA in chronic phase, but no such correlation was found in systemic, in blast crisis or accelerated phase. So what we wanted to find out, is there any correlation between VEGF expression and cathepsin L expression, and we found a very strong positive correlation between the two. When we treated the normal cells with VEGF, then the expression of cathepsin L was increased, thereby suggesting both the level of both the activity as well as mRNA levels were increased, thereby suggesting that the VEGF is overexpressed in this leukemia, which is responsible for overexpression of cathepsin L. Now, we demonstrated the same thing by using the cephexin promoter, and by doing a series of experiments. I am not going to go in the detail for these experiments. By deletion analysis, cyberactive mutagenesis, chip assay, electrophoretic mobility chip assay, we were able to find a 23 base pair VEGF response element in cathepsin promoter. Also, what we found is, although cathepsin VEGF levels were high in chronic phase, in accelerated phase of blast crisis, but the expression was low. So we previously, we and others found a number of CPG islands in the cathepsin promoter where it is methylated, and when we compare the methylation status of cathepsin promoter, what we found is there is extensive methylation in normal control or patient control, but in chronic phase, there the methylation was 15 to 20% as opposed to 65 to 80%. But in similar to normal individuals, the methylation status, there was extensive methylation in blast crisis, so suggesting that decrease in cathepsin expression in blast crisis was due to the methylation of this promoter. When we treated these cells with demethylating agent, there was a robust increase in cathepsin expression, mRNA, and activity, and as well as protein, suggesting that this was indeed because of the methylation status. Also, when we treated the cells isolated from accelerated phase of blast crisis with demethylating agent, expression of cathepsin increased, thereby confirming our findings. When we overexpress this protein, it increases the sensitivity to imatinib, suggesting that the decreased sensitivity of these patients in blast crisis was due to the decreased expression of cathepsin. These results were published in Journal of Cellular and Molecular Medicine, and then this was about chronic leukemia. We also studied the diagnostic and prognostic significance of cathepsin and cathepsin B in pediatric leukemia, and I'm not going to go in the detail, but we demonstrated that overexpression of cathepsin in pediatric acute leukemia is associated with poor prognosis. Then we studied the expression of the prognostic and diagnostics and the therapeutic relevance of cathepsin B, and this is the study design. We recruited about 106 pediatric AML patients and 35 healthy controls, and then we performed various assays which have been shown here. And what we found, this is the inclusion and exclusion criteria. I'm not going to spend a lot of time on this, but these are patient characteristics, and again, the total leukocyte count was significantly higher as compared to the healthy controls. And when we assayed cathepsin L and cathepsin B activity in both peripheral blood mononuclear cells as well as in bone marrow nuclear cells, the activity and expression in both these cell types was significantly higher as compared to the respective controls, and there was a direct correlation between cathepsin L activity, cathepsin B activity between in PBMCs and DMMCs, suggesting that the activity in DMMC mirrors that activity in PBMCs. Similarly, cystatin C expression was down-regulated in patients as compared to control, and so was cathepsin B mRNA. It was overexpressed in both these things. Now, this was also confirmed at the level of proteins. You can see in healthy control, this band is barely detectable, but there is a thick dark band in the patient samples. When we assayed cathepsin B activity after induction therapy, patients which responded to therapy, the cathepsin B activity decreased, and which did not respond, it did not decrease or increase in one patient, suggesting that it increases with the severity of the disease and it decreases with the response to chemotherapy. Then we performed survival analysis as a function of cathepsin B, and this is what we got. The patients were divided into two groups. One was labeled as high cathepsin B activity, in which the activity was more than the median value, and low activity where the value of cathepsin B activity was lower than the median value. And as you can see here, in both PB and DMMC, where the activity was low, the survival was for event-free survival was 429 days, and in high cathepsin B it was 247 days. Here it was 415 and 224 7 days. So 247 days. So suggesting that wherever cathepsin B activity is high, event-free survival is low, and wherever it is low, event-free survival is high. Same thing was true with overall survival. Here it was 787 days in low cathepsin B activity and about 295 or 285 days in high cathepsin L activity group. Thereby suggesting that high cathepsin L activity is associated with poor overall and event-free survival in AML patients. We perform multivariate and univariate analysis, post-regression analysis to find out if it can serve as an independent prognostic marker, and both in univariate and multivariate analysis, cathepsin B emerged as an independent prognostic marker. Then it is expressed at a very high level in AML, so we wanted to find out whether it is responsible for proliferation of these cells. So we subjected these cells, which were isolated from the patients, to cell cycle analysis, and as you can see here, significant more number of cells were present in S1, G1 or M phase of cell cycle where cathepsin L activity was higher, that was in AML, PBMC or DMMC as compared to the controls. Now if that is so, and then we found a strong direct correlation between cathepsin B activity as well as percentage of cells in S cycle, and we found a strong correlation. So to assess whether this cathepsin B was responsible for increased proliferation of these cells, we chemically inhibited cathepsin B activity by a synthetic inhibitor which is specific for this. This is CA74, and then we performed cathepsin B inhibition, effect of cathepsin B inhibition on cell proliferation. It was visualized under microscope and assayed by cell viability assay using MTT-assay. Also, cathepsin B inhibition of cathepsin B activity was confirmed by enzymatic assay using a fluorogenic substrate. And as you can see here, chemical inhibition result in inhibition or death of the AML cell after 48 hours. You see very little live cells or proliferating cells, whereas in vehicle control or untreated you see nice healthy colonies of the AML cells. Also, when this was completely inhibited and there was enzyme activity was about 90% inhibited, and there was about 50% survival or 60% inhibition of cell survival, 60% cells underwent apoptosis or cell death. Then we studied the effect of cathepsin B inhibition on cell growth, and we performed cell cycle analysis again. And as you can see here, in control cells, in control group, these cells were evenly distributed in various phases, whereas after 48 hours, the cells after cathepsin B inhibition using a specific inhibitor, about 54% cells were observed to be in G1 cells or apoptotic or necrotic phase. To assess whether they are in apoptotic or necrotic phase, we again perform MXM 4-PI assay for determination of apoptosis, and what we found is that about 80% of the cells after this treatment with the inhibitor after 48 hours were in apoptotic phase. They were undergoing apoptosis. This was further confirmed by performing caspase-8 assays. At 48 hours, there was about the activity significantly increased of caspase activity, which is mediator of apoptosis, and same thing was found with another mediator, that is caspase C and 7. However, there was no release of LDH from these cells after treatment, suggesting that it was not necrosis, but it was apoptosis. So, if cathepsin B inhibition is responsible for killing of these cells, we wanted to study the effect of doxorubicin, which is used for treating this malignancy, and we did computer modeling with the help of Department of Biophysics, and this is the active site of cathepsin B on the right hand side, where in colored balls and sticks, these are the inhibitors. Inhibitor for cathepsin B, and this is fitting in very nicely into the active site. But to our surprise, even doxorubicin was binding to the active site of cathepsin B even more tightly, and doxorubicin exhibited a dose-dependent inhibition of cathepsin B activity both in live cells as well as in lysate, thereby suggesting, and again, this is the interaction energy, and it is binding with higher affinity and higher stability as compared to the cathepsin B inhibitor, and some of the amino acid with which it is interacting is common. So I don't have a conclusion slide, but I want to conclude by saying that both these cysteine cathepsins can be used as a potential prognostic marker, and these results on inhibition of cathepsin B suggest that it can serve as a potential therapeutic target for the treatment of leukemia. These results were published in American Journal of Cancer Research in 2019, and these are the people who worked with in this project: Dr. Garima Pandey, Mr. Samaiya, and Prerna Jain. These are my PhD students. Dr. Sameer Bakshi provided us the sample for AML patients. Dr. Lalit Kumar for CML patient. Bhaskar Thakur and was from Department of Statistics, helped us with statistical analysis, and Dr. Manoj Kumar and Professor Puneet Kaur from Department of Biophysics helped us in molecular modeling. So research in my lab was funded by research grant from DBT, DST, and DRDO, and this is my group which have contributed in this funding. Thank you very much for your patient hearing, and once again, I again thank National Academy of Medical Sciences for selecting me for this oration. Thank you very much.
Over to Dr. Rajeshwar and Dr. Behra.
So thank you. Okay.
Thank you, Dr. Chauhan, for a very nice presentation, very comprehensive indeed. I'm most impressed with your details about the understanding of myeloid leukemia in children, as I'm a pediatrician myself. Very nice work. Congratulations, sir.
Thank you, sir. Thank you very much.
So thank you, Dr. Chauhan, for the very clear and crispy presentation. And you have very nicely told us about the role of cathepsin B in chronic myeloid leukemia and also in AML in children. You also told us their possible therapeutic role, particularly your work on the cell lines, and also their correlationship with the vascular endothelial growth factor or VEGF. So very nice lecture indeed. Thank you. We enjoyed it.
Thank you very much. Okay, Dr. Chudamani, madam. Yes,
Please present certificate and
Dr. Shyam Singh Chauhan It's a wonderful work that you have done on such a complex problem, with showing light of the day that this particular thing could be used for both for prognosis and maybe even for treatment. Thank you so much for so well elaborating on this subject and so much hard work that you have done. You really need to be complimented and congratulated. And I have the pleasure of handing you over virtually your medal as well as the citation and a check, which could be delivered to you at the convocation of the NAMS in 2020, or else it may be delivered to you by post. We are quite hopeful that the convocation should be done certainly in a few months' time.
Thank you very much, ma'am. Thank you once again. Thanks a lot, ma'am.
Thank you, Dr. Rajesh Dayal, Dr. Digambar Goyal, and Dr. Chauhan. Dr. Chauhan is now moved to Department of Biotechnology to do more researches. Okay, so now we move to the last oration, Dr. J.S. Bajaj oration. Dr. K.K. Sharma, can you please unmute and tell about the chairpersons and invite them?
Thank you, Dr. Srivastava. I'm really pleased to introduce the two eminent chairpersons of the Dr. J.S. Bajaj oration, Dr. D.K. Taneja and Dr. Mrs. Lydia Butler. Dr. D.K. Taneja is an eminent and very accomplished orthopedic surgeon of the country. Earlier, he has been professor and head of the Department of Orthopedics in Government Mahatma Gandhi Medical College, Indore, and superannuated as Director, Dean and Principal CEO of same eminent medical college of Madhya Pradesh. Recently, he is working and holding the position of Senior Consultant and Director of Arihant Hospital and Research Center and Senior Consultant at Central Hospital Limited of Apollo Hospital in Indore. Over to Dr. Lydia Butler. She is an accomplished obstetrician and gynecologist of the country and working as professor in the Department of Obstetrics and Gynecology of the prestigious All India Institute of Medical Sciences, New Delhi. She is not only contributing in the patient care and social services in the area of obstetrics and gynecology, but also contributing to a number of activities of the National Academy of Medical Sciences. Recently, she is member of the NMS Council. Over to Dr. Srivastava.
Okay, I request Dr. Taneja to tell about Dr. J.S. Bajaj oration, and subsequent to that, Dr. Meeza Butler to tell and invite Dr. Hari Kumar for this oration.
Thank you, Dr. Deepman Srivastava. It has been indeed a great privilege and honor for me to be asked by the National Academy of Medical Sciences to chair this important oration of the Academy. Dr. Jasbir Singh Bajaj, as you all know, is synonymous with the National Academy of Medical Sciences. I remember in 1966, in 1968 I joined All India Institute of Medical Sciences, I had met Dr. Bajaj for the first time, a tall person, empowering personality, starched apron, taking round with a few of his postgraduate students, and whenever anybody met him, he left an everlasting impression on him. Dr. Bajaj, as you all know, is a known endocrinologist of this country who had made an outstanding contribution in the field of diabetes, and his work has been internationally recognized, especially from the Stockholm in Sweden, where he got the doctorate of medicine. Dr. Bajaj has been a member of the Planning Commission, and he made a significant contribution and suggestion in charting the policies in the health sector. And Dr. Bajaj, as you know, has been the advisor and a personal physician to the President of India, to the Prime Minister of India. He has been one of the very few medical personalities who has been honored with Padma Shri, Padma Bhushan and Padma Bhushan. It is really a great honor that we in 2015, the National Academy of Medical Sciences started oration in his name as a Dr. J.S. Bajaj oration, which is given and delivered by an eminent person from the field of endocrinology and from whose work, outstanding work in the field of diabetes. With these words, I request now my co-chairperson to introduce the speaker, Dr. KVS Harikumar.
It has taken me back literally decades to when I first was an undergraduate at AIIMS with Professor J.S. Bajaj as one of our esteemed teachers. In the panel today here I see Professor Dave, Professor Sunita Mittal, who have also been my teachers. But Professor Bajaj, very rightly Dr. Taneja said, he left an indelible impression with his somber gait and yet the twinkle in his eye, and his insistence on going deep into the history of the patient. And over the years as a teacher, I have constantly recounted that to my students and told them the importance of taking a meticulous history, emphasizing the value of good sound clinical sense even in this era of technology and even as we see the impending advent of AI. But he would say, if the patient has been diabetic for 10 years, tell me her blood sugar for each of those 10 years. Every day I want to know the story about. And maybe that is part of the impression that he made, that despite my deep interest in gynae oncology, I could never shake off my interest in gestational diabetes. So these continue to be my true passions, partly because of the influence of Professor Bajaj. But now it is my pleasure and privilege to introduce our esteemed speaker today, Dr. KVS Harikumar. Dr. KVS Harikumar is a graduate and postgraduate from AFMC Pune and pursued DNB in endocrinology from the Medwin hospitals at Hyderabad. He was a university first in MD medicine, received a total of 4 gold medals during post-graduation. He took voluntary retirement from the command hospital at Panchkula in April 2019, having served the Indian Army for over 24 years in various capacities. He has published 210 research papers in peer-reviewed, indexed national and international medical journals and authored 12 chapters in textbooks of medicine and endocrinology. He was awarded the Shakuntala Amirchand and M.N. Sen Oration Awards from ICMR, Diabetes Lecturership from API, Thyroid Star Oration from the Indian Thyroid Society, Dr. A.R. Seth Gold Medal from Endocrine Society of India, Brigadier S.K. Majumdar Memorial Trust Young Scientist Award Fellowship of the Indian Society of Hypertension, and Best Researcher Awards from the RSSDI and UPDA. He works as Editor-in-Chief of an international medical journal, editorial board member for 6 other journals, and reviews for many endocrinology and to deliver the Dr. J.S. Bajaj oration. Dr. Harikumar, over to you, sir.
Good evening, ma'am. Good evening, sir. Respected chairpersons, can I have the option of sharing my screen, please?
It is given, you can start.
Yeah, thank you. Respected Chudamani ma'am, Professor Dave sir, Professor Deep Srivastava sir, and entire eminent faculty, chairpersons, everybody. I thank ma'ams for selecting me for the, there is no words to say about Professor Bajaj, but I'm too small to see the accomplishments of what sir has achieved. And it's with humility I accept this, and I thank the ma'ams for giving me an opportunity to share some of the work what we have been doing in the last decade or so about diabetes and I shall spend next 15 to 20 minutes in that area. I hope you can see my slides now.
Yes, you can please continue.
A lot has been said about Professor Bajaj, but two important things what you need to know is, he is the first colored man to be elected as IDF president. Colored man actually is a derogatory term, but that was the stature of this individual, that over Europeans and Americans, he was selected as president of International Diabetes Federation for the first time. And he was the one who actually did a thesis on pre-diabetes before WHO coined this term in 1961. And to his credit, malnutrition related diabetes is named as an eponym after his name as Bajaj syndrome. So that is what I contribute to the Professor Bajaj. So to come into the talk, diabetes, you all are aware, it touches everybody's life at every portion, every specialty, every individual, every house, and we have been growing by leaps and bounds, unfortunately not able to control the way we should be able to. There is something known as rule of halves, which is there for all chronic disorders, especially with hypertension and diabetes. Of the people who are estimated to have diabetes, only 50% are diagnosed, and out of the 50%, only another 50 receive the care, and another 50% reach the targets, and only out of these, another 50% only are able to reach the outcomes of preventing the complications. So there is plenty of gap where we need to cover up in this chronic care disease segment. I shall cover the research in the following headings: something about etiopathogenesis, something about the management issues of diabetes, and something about the complications, what we have worked in the areas of diabetes. Coming to etiopathogenesis, in chronic disorders, to get out of prevalence is very easy. Everybody can do a prevalence study, but to identify the incidence actually is very difficult. We followed up quite a number of soldiers for almost close to 25 years from the stage of recruitment to the stage of retirement, and we had a close to 6 lakh person year follow-up, and we showed a prevalence of incidence of type 2 diabetes only 0.4 per 1000 person years. And Professor Mohan showed from his data of Chennai Urban Rural Study the incidence of 20, which is way above than what we have shown, possibly because of the active lifestyle of a uniform service does give you a protection from developing into a diabetes. And looking at the changing demography of the diabetes in the last couple of decades, young diabetics, early onset, all of them are becoming more common nowadays. So we have studied whether they are actually, is it a type 1 or is it type 2? So we did study a group of young diabetics who are age less than 35 years, duration less than 6 months, and all of them were non-obese. We checked their antibodies to look at type 1 and beta cell function, and then looked at the ketosis. And to our surprise, even in non-obese young diabetics, type 2, that is absent ketosis and antibodies absent, was the most common group despite showing similar signs as type 1. The type 3 diabetes is what is commonly described as pancreatitis related diabetes due to a secondary one. We all know that visceral adipose tissue is more damaging than the subcutaneous adipose tissue. So we studied whether the visceral adipose tissue contributes to diabetes even in patients with chronic pancreatitis. So we took 100 patients of chronic pancreatitis who had developed diabetes and who did not have diabetes, and did one of the gold standards of estimating the visceral adipose tissue, the DEXA scan in all of them, and we showed that for the first time the visceral adipose tissue was a determinant even in pancreatitis induced diabetes as a risk factor for the diabetes. Another important one where people have been using higher dosages of insulin in clinical practice. What is the reason behind it? We looked at patients who have used higher dosages of insulin with requiring almost close to more than 2 units per kg per day. So closer to 100 to 150 units per day. What is the requirement? Why should they require so much of usage of insulin? And to our surprise, the biggest factor was the daily carbohydrate consumption. The recommended for all diabetics was less than 130, and the people have been taking more than 200 to 220 grams per day, contributing to a higher insulin requirement, and which needs to be addressed in the clinical practice to reduce it. Coming to few issues about the management. The commonly talked about the management is ABC goal in diabetes. A is for A1C, B for blood pressure, and C for LDL cholesterol. All three have to be ideally matched to prevent the cardiovascular complications associated with the diabetes. So we studied close to 1,000 patients, and only 9% of patients had the 3-point goal achieved. This is the both males and females put together. There is hardly anybody who is achieving the goal. Individually, BP was the best controlled parameter out of the three, but HbA1c was the poorly controlled. What are the reasons for it? The surgery, another major issue of the management. We studied a profile of a novel surgery for controlling the type 2 diabetes. Usually the remission rates were seen maximum with the bariatric surgery, and we started a cohort of surgery which is a novel surgery at that point of time, interposing ileum into a head and then doing a sleeve gastrectomy. This will change some of the enteric hormones which are responsible for the diabetes control, and sleeve gastrectomy will have a restrictive component associated. So we started the study in 2008 and thereafter followed up these patients. The patient cohort kept on increasing, and our observation further boosted our confidence about the results of the study. And then we finally, at the end of almost close to 6 years of follow-up, we could find out some predictors of remission after metabolic surgery. This was one of the first papers to give a scientific scoring as to who are going to benefit if you offer them a surgery. So this was predicted as DAR score calculator. So there are 7 parameters which we have identified: the age, the body mass index, the duration of diabetes, presence of complications, and preoperative insulin use and stimulated C-peptide. All of them have been useful in predicting the remission after the surgery, because it's a irreversible procedure. So whenever we subject them for a bariatric procedure, you need to understand the benefit of it. So this was one of the first papers from India which have shown that there is a score which can be calculated and you can prognosticate the patients about the benefit of surgery later on. Type 1 diabetes, unfortunately, has got only insulin as its treatment and nothing else beyond insulin right from its discovery. Almost century years have passed, but we are only using insulin. The type 2 has been expanded with the usage of many new molecules. This was one of the studies which we did using a novel incretin modulators in the usage of type 1 diabetes. We randomized patients into 3 arms. One arm used only insulin as per the standard of care. Another arm used insulin plus sitagliptin, which is a oral drug. And third arm we used insulin plus exenatide. So we could see a A1C reduction with the usage of any of these incretin modulators, more with the injectable preparation than with the oral preparation. But to our maybe same expectation or in tune with our known literature, there was no change in the C-peptide, even though there were some animal studies which have said that GLP-1 receptor analogs have been shown to help in beta cell regeneration, but that didn't happen in our study. We followed them up for 1 year after onset of diabetes. Another important area what we have studied was the usage. Can we find some alternatives of usage of insulin in the critical care setting? Usually the insulin is the cornerstone at this point of time in critical care. But again, a GLP-1 receptor analog, the liraglutide, we studied 120 patients who were admitted to an intensive care unit. and we showed that giving this liraglutide did give a comparable control to the insulin without any increase in the side effect. So this was another novel study which has been studied from our group. Coming to the group of complications, the difficult to address and what are the issues concerning this. The prevalence of microvascular complications, and these were not, the prevalence data was not much studied earlier. So at the time of presentation, we studied close to about 1500 patients. Almost 48% of patients had microvascular complications, mostly neuropathy and a combination of nephro and retinopathy. So this was, almost every second patient with type 2 diabetes had a microvascular complication to be bothered about. Some of the differences or some of the issues in identifying the microvascular complication we addressed in this study. Usually, Madam knows very well, gestational diabetes is a transient state of hyperglycemia. Usually you don't expect any structural changes in it. We did whether are there any functional changes associated in the retina due to this transient hyperglycemia. So we studied using the visual evoked potential in the gestational diabetes patients, and we did the same in type 2 diabetics who are pregnant otherwise. So we demonstrated for the first time that there is long latencies and low amplitudes in patients both with GDM and type 2 diabetes than when compared with controls, thereby meaning to say that the functional changes precede much before the structural changes, and possibly to push it further into clinical practice, it's important to identify these functional changes and educate the patients much early in the clinical course and take corrective actions at that point of time. We are all in the virtual mode now, and courtesy the pandemic what is going on, but we did this study almost 6-7 years back about taking an image in the clinic and getting the expert opinion who is located distantly, which is transmitted to him instantly, and the expert retinal specialist gives you the opinion on the retina image what is being provided, and we did compare with the fundoscopy immediately, and this was shown to be comparable to the conventional fundoscopy. So now it's more or less practiced routinely, but was not at that point of time. Another most difficult complication in diabetics what we get is something known as meralgia paresthetica. It is like a excruciating pain in the thigh. It's a femoral neuropathy. And patients take lot of NSAIDs, SSRIs, tricyclic antidepressants, but it is very, very difficult to control. So we did inject botulinum toxin for these patients, intradermal injection. You can see it's in a grid formation. We did inject the botulinum toxin, and we followed the patients for 2 weeks, 6 weeks and 12 weeks to see the pain relief. And this was shown to be that botulinum toxin helped in significantly in controlling the pain in these patients, which was one of the first studies to report the same in patients with type 2 diabetes. Few other aspects I will just share with you. Discordance in lipids actually is one of the important factor in clinical practice. Despite patients having reasonable exposure to statins, there is lot of residual risk associated. People still have lot of cardiovascular ailment. What you need to look at is something known as a non-HDL cholesterol in all type 2 diabetics. We looked at, are we justified by doing only a LDL cholesterol as a benchmark in looking at type 2 diabetes? And we showed that if you look at only a LDL cholesterol, you are likely to miss quite a few number of patients, and you are not able to control these residual risks, which is going to cause the cardiovascular issues. So this paper highlights that you need to look at the discordance between the traditional and novel risk factors in patients with type 2 diabetes. Some of the community or patient-based studies which we have done to look at the empowerment of patients and attitude of healthcare professionals about diabetes. Mostly important finding, I can only say that the old people and longer duration of diabetes had more comfort with the managing diabetes themselves than when compared with people who are young or early, despite more aware of the current day knowledge, but still the old people had a edge in managing their diabetes on their own. Another very unusual complication of diabetic kidney disease, which was acquired perforating dermatosis, where there is a perforation in the epithelium and collagen extrudes out. This was what we have compiled and then published in one of the good journals. Vitamin D has been almost described for reason for plenty of the other things, including the metabolic disorders, other than the skeletal effects. We did study the prevalence of vitamin D deficiency across the spectrum of glucose intolerance, and some data in the gestational diabetes about the relation between vitamin D and parathyroid hormone and its effects on the insulin sensitivity. I don't want to go into details for the paucity of time here. The clinical implications of all our studies put together, I'll just summarize. Coming to etiopathogenesis, I can only say that good lifestyle reduces the incidence. There is enough to say that. So please adapt a good lifestyle. Type 2 still remains common even in the lean diabetics, and visceral adipose tissue is responsible for even pancreatitis-induced diabetes. Looking at the management options, unfortunately the ABC goal, the rate of achievement are abysmal. There is metabolic surgery, which we have and a novel scoring system developed, and possibly in some select patients you can use incretin modulators in type 1 diabetes as well. Coming to complications, the epidemiology again is frightening as far as diabetes is concerned. We use visual evoked potential for early screening of gestational diabetes and type 2 diabetes, and telemedicine can be used by everybody for retinopathy. Other issues, lipid discordance is important as far as looking at the cardiovascular risk assessment, and vitamin D is low in diabetes and should be corrected wherever you find low vitamin D. And DM attitude and empowerment is important, because all chronic care disorders, it's the patient empowerment which determines the outcomes tremendously. I have taken the photograph of the Indian cricket team despite them not doing well, because you can identify the players very easily. I thank my mentors and coach, Professor Garg, Professor Modi, Professor Prushti and Professor Bipin. All my colleagues from other departments who have helped in referring the patients, who have did all the tests, all the residents, and all the lab staff and nursing staff who took part in the studies. Obviously my family members who helped me in carrying out events whatever I wish to, and finally the patients who repose their faith whenever we ask for samples, we ask for signatures, we ask for extra samples and procedures. So with this, I thank all of you for giving me an opportunity to share our work, and thank NAMS for giving me this prestigious honor on me. Thank you all.
Okay, over to Dr. Taneja and Dr. Nizia Batla.
I was totally spellbound. It's a huge volume of work, and so comprehensively you have put it together and traced the whole journey from so many different angles. It is really monumental. It was wonderful. Thank you. Dr. Taneja. I think I'm muted.
Yeah, excellent oration, lucid discourse, very explicit, very clear in your research targets, and many things that we have learned. The need of physicians are all the time. The day we enter in the medical college, we have been hearing diabetes. Until we at the end of our life, we are all the time struggling with diabetes. Thank you very much, and I greatly appreciate, and I like to thank you and myself and my co-chairperson for an outstanding work, and I would like to thank Dr. Suraj Churamani and other distinguished members of the National Academy of Medical Sciences for asking both of us to chair this session, which is a greatly an honor itself. Thank you so much, Dr. Saroj Chudamani.
Dr. Chudamani, ma'am.
Thank you, Dr. Colonel K.V. Hari Kumar. You have given a wonderful insight of research in diabetes and the very word that lifestyle plays a lot role, and this what our Prime Minister has done the whole world, that he's taking yoga for everyone. Maybe the next generation or next few years will show the impact of yoga in public. Maybe diabetes does come down. Thank you so much for highlighting your work, and we are very much honored with your presentation. And the NAMS takes the privilege of awarding you this medal, the citation, and carries a check which will be delivered to you at the convocation, if which is likely to happen in near future shortly. Thank you so much for giving insight of diabetes. Thank you.
Thank you, ma'am. Thank you.
Thank you, Dr. Taneja, Dr. Nija for chairing the session, and Dr. Hari Kumar for excellent talk.
Thank you.
Now I request Dr. P.K. Dave, Emeritus President NAMS, to give concluding remarks. Sir.
It has been extremely good evening and a pleasure to listen to all these people, learn so many things about diabetes, about molecular biology, about physics, and of course I can see that a lot of people from All India Institute, Dr. Nija Batla, Dr. Taneja, and all these people are here. It has been a great pleasure. I must congratulate all the speakers who have actually taken their heart out and give so much of knowledge to us. So this is, I think, a plus point for the academy. The academy has learned so much from these people, I think, and maybe I think some of their research can be transformed into a proper clinical value, proper clinical life here. I again thank the Academy, the NAMS, Dr. Chudamani Gopal, about everything. Thank you very much.
Okay, sir. Thank you, sir, for your kind words. Now I request Dr. Chudamani, NAMS President, to give her concluding remarks. Madam, please.
It has been a great learning today in this, listening to all orators, their wonderful presentation, their hard work performed over years, and I'm sure people who have joined this oration in the form of online, offline, as NAMS fellows, NAMS members, or students, other people from any institution, must have been to them also a very great learning experience. Each one of these speakers spoke so well, and so did the chairpersons of those orations. I must also thank the service provider, Sunny Datta. His performance has been good this time. Most of the people have been able to listen, and he has not disturbed us by saying your time is exceeding, your time is exceeding. Thank you so much.
Because it has
once again thank all the speakers, all the chairpersons, and all the NAMS office bearers, particularly Professor P.K. Dave, who has been there all the time blessing us and inspiring us, and also Dr. K.K. Sharma, who has coordinated so very well, and the moderator, Dr. D. Srivastava. And I must also thank the staff of the National Academy, who has been working very hard to make it as a good show, successful evening today, and successful event. I would like to somehow or other connect to Dr. B.M. Hegde, because he is a wonderful orator. We could not listen to him. This has been rather bad luck today that he could not get connected. It would have been a pleasure to listen to him. I would like to convey to him that we have missed him, and I would like to also say that Dr. P.M. Tandon, it was a reward for us how much insight he gave about Lakshmipati, Achanta Lakshmipati, which we had really not known. So what a great thing that he came and gave time and appraised us. And to all the chairpersons like Dr. O.P. Kalra, he gave his personal remarks about Radhan Oration, Dr. P.N. Tandon, Dr. U.K. Mishra, Dr. Salman Singh, Dr. Kameshwaran, Dr. Rajeshwar Dayal, Dr. Digambar Behere, Dr. D.K. Taneja, Dr. Neeza Ratla. Each one of them spoke so well. It was heartening, and I'm really grateful for all of them that they accepted to be chairing these sessions on such a short notice. May I tell you that I was able to talk to them just about 48 hours or 24 hours before this event, and they were also, they all obliged me by accepting my request, and I'm indeed very grateful to all of them and each one of them. Thanks. And all the speakers have done such a wonderful job. Wonderful. Your expression, your slides, your theme, your work, and your message. Absolutely fantastic. Thank you so much.
Thank you, madam, for your kind words. With this, we have come to the end of today's program. And please remember, tomorrow, same time, 3 to 5, we are going to see the NAMS awards. All these orations are, sir, published in our annals. Okay. It is already indexed, so we are going to publish soon all articles, all orations in the form of articles. I would like to thank all NAMS staff, as madam has already said. They were working for last 3-4 days, almost more than the office hours, for preparing certificates, medal, and so many other things, telephoning and letters to all. Also to web service provider Sunny, today it was better than the something different, but anyway, thanks to Sunny, Amit, and your entire team. And please tomorrow also provide the same services. And as I requested, tomorrow NAMS Awards 3 to 5. Please provide link at 2:30 so that everybody is connected and they can download WebEx. Yes, madam, you wanted to say something? Yes, madam.
Kindly acknowledge that we missed Dr. Vinod Paul, and he could not join because of his very stormy meetings going on. So please tell this to all people who have joined us in this meeting, please.
Okay. Okay, madam, I will do. This is, there is an important meeting on vaccine which is going on. Still it is on, but I will convey your message. And see you tomorrow. Anything else that you want me to say, or shall I?
Please do close. Please do close.
So thank you very much, all of you. See you tomorrow. Thank you.
Thank you, everyone.